nutrients and fluids are, ooh, close that, are absorbed. It's in the small intestine, okay? And then the ileum terminates here in near the cecum, at the ileocecal valve here. So food's going to pass from the small intestine into the large intestine. Now in the large intestine, also known as the colon, that is where your feces is made. So in the small intestine, that's where the food is still being broken down, and all the food is being, the nutrients are being absorbed, and waste is being sent to the large intestine. That is where the stool matter is made, right? The large intestine does have some control over water being excreted and absorbed, so to make your stool harder or softer. But for the most part, stool, any issues like with um, fecal impaction, that kind of stuff, that's affecting the large intestine versus the small intestine. You'll see when we go on to talk about disorders. Um, and yeah, so and then all of the organs lie in the abdominal cavity, also known as the peritoneal cavity. And that cavity is protected with a layer, a serous membrane, just a clear protective layer, called the peritoneum. Okay. And hence, when that layer becomes inflamed, then you have peritonitis. So just touching on some things that will be common in all these GI disorders: diarrhea, lower GI, that is. Diarrhea, it could be called an infectious process. Usually if it's acute, then it's usually because of some sort of infection. Now, diarrhea doesn't mean, oh my God, I went to the bathroom once and had a loose stool. It means multiple watery stools. And multiple stools in an hour. So that will be diarrhea. So acute, like I said, is usually caused by infection, but chronic could be related to chronic bowel disorders like IBS, inflammatory bowel disease, which includes Crohn's and ulcerative colitis, or it could be an issue with malabsorption. The intestines, for whatever reason, aren't absorbing the nutrients properly, or water or what have you. It could also be due to hormones like hyperthyroidism. So with diarrhea, I mean, I'm pretty sure everyone's aware of the signs and symptoms of diarrhea. So remember that, especially when it comes to your exam. If you're giving someone a medicine that could potentially give them diarrhea, such as a prep for a colonoscopy, then you have to consider all the signs and symptoms of diarrhea, right? Nursing considerations, the treatment, it's always, I mean, any treatment for any disease, you always want to start with least invasive first. Least invasive first, meaning, if I don't need surgery, I shouldn't be getting a surgery. Surgery should be the last resort for most things. Now, don't get me wrong, certain things are a surgical emergency, but for most things, if surgery and invasive procedures can be avoided, then we want to avoid them. So oral rehydration is going to be most important with diarrhea, especially for children and babies. You don't want to have to start an IV on a small child or a baby. That's why they make Pedialyte, right? Remember, small infants, you don't want to be giving them just water, not when they're still in that bottle feeding age range. You want to give them something like Pedialyte, or oral rehydration solution. Monitor vital signs. We already talked about last week. Weight, weight, weight. Body weight in children and infants is going to be the best indicator of their fluid hydration status. Okay. Um, we are going to monitor, I's and O's. Of course, you want to monitor output, urine output, especially to know about their hydration status. But don't worry, we will talk about that more next week when we talk about fluids and electrolytes. But you still need to know, okay, diarrhea, what's the biggest risk? It's going to dehydrate someone. You saw on the last slide I put on there, it's the leading cause of death in children under 5 in most countries, not America, but in developing countries and underdeveloped countries, diarrhea is killing children. So you want to administer fluids and then know about what medications might prevent or stop the diarrhea. Also, assessment. Remember, assessment always comes first. So aside from your physical assessment, like listening to bowel sounds, the bowel sounds are likely going to be what? Hyperactive, right? They're going to be hyperactive with diarrhea. So besides listening to bowel sounds and observing, you also could be collecting a stool sample. You could test stool for C. diff. You could test it for parasites. So that is often some labs that are ordered. Besides the electrolytes and looking at hydration, we want to find out what's causing the diarrhea. And then same constipation. Everybody knows what constipation is, infrequent or difficult passage of stool, right? Now you have to consider, what does that patient consider normal? Some elderly people, they may not have a bowel movement every single day. Maybe for them, they'll tell you, old people are obsessed with their bowels. They'll tell you, oh, I only have a bowel movement every third day. And that's normal for them. But now it's been 5 days since they had a bowel movement. Now they're constipated, okay? Old people in general, remember, motility is going to slow down. They're going to have some muscle weakness. And because of that, their large intestine is able to expand and make room for more stool. So they are usually the ones that are at risk for for uh, fecal impaction. Sorry. Um, Also, any neurological disorder, if it's going to affect the movement, like if you're paralyzed, if there's some nerve damage, multiple sclerosis and Parkinson's, you'll see when we talk about neurological disorders, if the nerves carry all the signal from the brain to tell the rest of the body what to do. So if you have a nerve disorder, or if you have even, some brain damage disorder, it can cause a disruption in that signal getting to the intestines to tell them to move, tell peristalsis, right, to occur with the contraction and relaxation of those muscles. You could have constipation due to an obstruction, and we'll talk about obstructions in a minute. And dietary. I'm telling you right now, we're learning GI. You need to read that nutrition book. I emailed you the chapters. There is a specific chapter in the nutrition book on GI disorders, and you'll see on the study guide, you're going to need to know dietary considerations, considering we're talking about the digestive system. Constipation, again, the findings. Typically the pain's going to be in the left lower quadrant, and we'll talk about, I'll show you, because that's the area right before it gets to the rectum. That's the end of the large intestine. That's where the sigmoid colon is. So usually when you have issues with the large intestine, it's usually around that area, and you have left lower quadrant pain. Now, if it was an issue with the cecum, or the ileum, either the beginning of the large intestine or the end of the small intestine, then it will be right lower quadrant pain. So you get what I'm saying? We could talk about inflammation all day, but if you don't know the anatomy, if you don't know where these body parts are and how they function, what does it matter if you know about inflammation? You need to know the function of these organs and how they work and where they're located. Because if you know the sigmoid colon is located in the left lower quadrant, then you're probably going to have pain in the left lower quadrant with anything to do with the sigmoid colon. Um, you want to avoid a lot of people, especially elderly people, can become dependent on laxatives. So dependent that they can't have it. It can lead to constipation, abuse of laxatives. Okay. So you want to teach them about that. And then discuss with them signs and symptoms, because if it's more than just, oh, a little motility issue or fecal impaction, if they have an obstruction, you'll learn in a second, this could be an emergency. So non-inflammatory, let's talk about bowel disorders. So first, non-inflammatory. I'm sure everyone knows what a hernia is, or at least knows what one looks like, and maybe you didn't know what it is. But it's a soft mass, usually found on the around the abdominal wall. But for men, it can also, or boys, young boys, babies, whatever, it can also occur in the scrotum. What's happening is you have a loop of bowel that has now poked through a weakened area of the abdominal muscle, right? So, you know, your diaphragm is up in the upper abdomen. Remember, we saw the hiatal hernia, where the stomach is protruding through the diaphragm. But in the lower abdomen, a hernia is going to be the intestines are protruding through a weakened abdominal wall. So here's all the different types, and you don't need to know, you're not a surgeon, okay? You don't need to know epigastric versus umbilical versus, you know, as long as you understand what a hernia is and what the complications could be. Risk factors is going to be anything that increases the pressure in the abdomen, heavy lifting, bending over, lifting heavy. A lot of men, especially, get hernias because of their work, the type of work they do. So men are at higher risk. Women during pregnancy, they can get hernias, especially even, you know, during the delivery. Some women end up with you know, a umbilical hernia, you know, because of the pressure of the baby pushing on the rest of the organs. Babies end up with hernias, and all that crying they do increases abdominal pressure, you know, pushing, making it easy to push a loop of bowel out. It could be genetic. And also remember, elderly people, they're everything's weaker. Their muscles are weaker, they're atrophied. So it's a lot easier to get a hernia if you're old.
I have a question.
What's up?
So basically, just so I understand, like a hernia is just like a displacement bowel, like in the abdominal like cavity.
It is a loop of bowel that for well, really, it's it doesn't actually, hernia is going to be an organ going through a whole, because really you could have, your brain could herniate into your like into the region of your spinal cord. So saying hernia is like an organ is poking through a hole. So for these lower abdominal hernias, it's the bowel poking through this hole in the muscle. That hole shouldn't be there. But like with the hiatal hernia, it was actually the stomach poking through the hole of the diaphragm, remember from last week? So hernia, like it, when there's a herniation, or you say something herniated or whatever, because you could have a herniated disc, right? The herniation is that bulging, that protrusion through an opening that shouldn't be there. Does that make sense?
Yes, it does.
Okay.
Thank you.
Yes, but for the purpose of GI right now, we're only talking about intestinal hernias, and we talked about a little bit about a hiatal hernia. With the hiatal hernia, your main thing is just teaching about GERD. But with these intestinal hernias down here, the main concern, I mean, like you've seen, these are hernias. These are all hernias. This is an umbilical hernia. This is some other, you know, abdominal wall hernia. So you'll see them. And then down here, you will even see, especially old men, they can have huge scrotal hernias. It's a difference between scrotal edema, which we'll talk about later, which is just swelling and fluid, than an actual hernia that is a loop of bowel down in there in their scrotal sac. So these are different hernias. Usually a hernia is harmless. It does not require treatment if it's not incarcerated. So usually if it's usually doesn't cause any pain, doesn't cause any symptoms. It's just, you know, for lack of a better term, ugly. People just don't like looking at it, or it's weird, you know, it's just something, oh, I don't know what happened, but I got this lump here and I don't like it. But as long as It can be pushed back in temporarily. Like if I stick my finger in this person's belly button, I can actually push that loop of bowel back in the hole, you know, temporarily. Is it going to pop back out? Yes. But the fact that you can actually push it back in that means it's reducible. I can reduce the size of it. I can push it back in the hole. Okay. I can push this loop of bowel in this image here, this animated picture here. I can push that back in, then it's reducible. When this hole becomes too tight around the loop of bowel, that's when you say it's incarcerated or strangulated. That is the danger of having a hernia. So if it's not incarcerated and it's not strangulated, you really don't need to do anything. I mean, you could teach them, you know, like people do things like tape a quarter to the belly button, or they have certain abdominal binders you could use or whatever. But for the most part, you don't really need to do anything. But if it becomes incarcerated, signs of that, one, it's going to be painful and it's going to lead to necrosis, cell death. If you've got a tight, you know, noose around this loop of bowel, it's going to die off. This loop right here is going to turn gangrenous, it's going to turn black, it's going to die. And what's going to happen then? Now you're going to be at risk for sepsis. You do not want dead tissue inside your body, okay? It's going to be at risk. Now it's dead. It's going to be at risk for rupture and leaking all the contents of this intestine out under the skin. Again, sepsis, death. So an incarcerated bowel is can be a surgical emergency, okay? So that's the only complication with hernias. Another non-inflammatory bowel disease is irritable bowel syndrome. Irritable bowel syndrome is really, it's just a dysfunction of your bowels. I mean, these people tend to have like a cycle of diarrhea and then constipation. Things don't ever seem to be right. They're either always constipated or always having diarrhea. There is no test for irritable bowel syndrome. And don't get irritable bowel syndrome mixed up with inflammatory bowel disease. Irritable bowel syndrome has no tests. There's so many speculations on what could cause it. Is it diet? Is it, you know, a genetic thing? Not sure. Is it stress? Is it related to depression and mental health? We don't know. But here is the diagnostic criteria for that, okay? We give patients education on how to prevent diarrhea or how to prevent constipation or how to treat the two. But there's no like specific test. So this right here is the diagnostic criteria. If the patient came in and they are having recurrent, they have this chronic recurrent abdominal pain, it happens at least 3 days a month in the past 3 months, like every month, and then they have 2 or more of these findings down here. Risk factors, you know, women, we're just so sensitive. We have all this stress. We carry the weight of the world on our shoulders. So, of course, we will be at high risk for irritable bowel, stress, and then again, diet. A lot of it is probably just dietary. I mean, in America, our diet is so horrible. So, diagnostic tests, again, these are not tests. You're not going to get a CBC and be like, oh, okay, they have irritable bowel or albumin or anything else. No, you're doing these tests to rule out other conditions. You would do a CBC, you know, maybe the white blood cell count is high. So maybe they have actually an infection if they have a left shift, right? Or maybe the white blood cell count is high and they actually have inflammation and no left shift. So that would tell you, okay, it's probably not irritable bowel if there's an abnormal CBC. Blood albumin, that will be testing like their protein nutrition status. And when we talk about liver in a second, that would have something to do with liver failure. But it wouldn't tell me what's going on with irritable bowel syndrome. You know, it would just rule out malnutrition. ESR, what is the ESR again? I'm not even going to tell you. What's the ESR?
Erythrocyte sedimentation rate.
Oh, cool.
And what is it?
Why
do we test it? Why do we look at it?
To test your red blood cells.
Jumanji is on Olympia stage. Christian Guzman, you guys know he is.
Information, remember?
Information.
On the
ESR is
exam, it's an
information.
inflammatory marker. So on the exam, there was a question. It's okay though. I want everybody guess as much as possible. Please just don't sit here silent because I'll fall asleep at my computer. But it's an inflammatory marker. So there was a question on the exam about rheumatoid arthritis and a patient. How would you know the treatment is working? You wouldn't look at their rheumatoid factor because that's just telling me, does the patient have rheumatoid arthritis or not? We already know they have rheumatoid arthritis. But if I looked at their ESR or CRP, C-reactive protein, those are inflammatory markers. And if a ESR was elevated on this patient, then I know they probably have an inflammatory disorder going on. Maybe they have Crohn's or ulcerative colitis. When we get to those, it'll remind you of the, those are autoimmune disorders. So they're gonna have an elevated ESR. Occult stools is checking for blood in the stool. You shouldn't have blood in your stool with irritable bowel syndrome, but you might have blood in your stool if you had ulcerative colitis. And what is the hydrogen breath test for? Anybody? It was in last week's lecture. What am I testing for?
What was the question, Professor?
What is hydrogen breath test for? What am I testing for?
I'm sorry, I can't hear you.
Pylori,
Yep, H. pylori, H. pylori infection. So again, you see these tests, there's no test for irritable bowel, but what you would do is by deduction, right? Okay, cross that off the list. The CBC is normal, so we know they don't have an infection or inflammation. Albumin is normal. We know they're not malnourished or experiencing liver failure. Oh, Madison got kicked out. Hold on, girl. Here I come. Let me.
No, I'm back in now. I'm good now. Thank you.
Oh, it's a delay in the chat. My gosh. Okay. ESR. If I know the ESR is normal, then I know, okay, they don't have an inflammatory disorder. They don't have blood in their stool. They don't have H. pylori. But they're still having this, and this going on. I guess they must have irritable bowel syndrome. And that's how that's diagnosed. Does everybody get that? There's no test for irritable bowel. The symptoms really honestly are going to be the same with any other diarrhea, constipation. That's really all they're going to have is recurrent diarrhea and constipation. So any education is going to be geared towards preventing diarrhea and constipation. So high fiber diet, and the things I already told you about diarrhea and constipation, avoiding foods that are going to irritate the gut. Medications, again, Imodium is anti-diarrheal medication. You need to know a little bit about Imodium and Lomotil. Those are the two anti-diarrheal medications. Psyllium, which is also Metamucil. Okay, if anybody's familiar with Metamucil, it's like a fiber supplement, right? Fiber is a bulk forming laxative. So unlike some other laxatives that might give you diarrhea, fiber is really, it's going to help you move your bowels, but also make a nice formed bowel, or I'm sorry, a nice formed stool, excuse me. So that's why you encourage fiber in everybody, except for those with inflammatory bowel disease. And then of course, any laxative you're going to discontinue if they're having signs of excessive diarrhea, if they are having too much cramping, abdominal pain. Lubiprostone is it's also known as Linzest. You probably see commercials for that, but that's for chronic constipation. And then this is just another medicine for chronic constipation. These probably won't be on your exam, but just letting you know what those meds are. Non-inflammatory bowel, so bowel obstruction. Now, bowel obstruction can be related to a lot of these other disorders we're talking about. There's many different things that could cause a bowel obstruction. What you need, well, you need to know, like even a hernia, if it becomes strangulated, not only can blood not get to that hernia, but how is food going to pass through there? How is stool going to pass through there? If you have a hernia, it could lead to a bowel obstruction. If you have a tumor, cancer, that could lead to a bowel obstruction. If you have a whole lot of inflammation and swelling in your intestines, edema can lead to blockage of the bowels, okay? So it could be mechanical or non-mechanical. Mechanical would just mean a blockage, right? Something is physically in the way of the passage of stool or food. Versus, excuse me, non-mechanical, which is also called functional. It means the bowels just aren't working. There's no motion in the ocean, okay? There's no movement, no peristalsis, and so the food is just sitting stagnant. A common cause of this is use of opiates. If you are using, if you're taking pain medication regularly, you can end up with serious constipation issues and even an ileus, which is your bowels just basically went to sleep. They're not moving, they're not doing anything, they're just there. So a paralytic ileus can occur after surgery because of anesthesia. It can occur after you've had any abdominal surgery when they cut you open and they're manipulating your organs in your abdominal cavity. It could kind of shock your intestines, like, whoa, sit still. I don't know what's going on. There's somebody in here moving all around. Everybody just sit still and be quiet. I don't want to get hurt. So what happens is then your bowels go to sleep. That's an ileus, okay? So what you need to know is you cannot survive without being able to pass stool, okay? You cannot survive without being able to get rid of this waste. So we talked about the causes again. Obstructive, a mechanical obstruction could be, like I said, with the elderly people or anybody. You could have a fecal impaction. You got so much stool in there, and maybe you haven't drank enough water, so it's like a dry, hard stool, and it builds up, and now it's blocking the outflow. You could have a volvulus, which is just this in this image. It's a twisting of the bowel. You can also have like I said, these could be tumors or polyps. These are all things, and this is scar tissue, adhesions. These are all things that can, like the scar tissue, like keloids. When you see people with a keloid on their ear or something, imagine that occurring around your bowels. It's going to not, keloids and scar tissue and fibrosis, it's all the same thing. It's thick. It is not forgiving. It's not elastic. It's like thick, leathery skin, basically. And because of that, if that becomes wrapped around your bowels, then, or if it attaches, if you have adhesions inside the bowels and now it's closed the walls, you're going to have an obstruction. And then again, when we talk about diverticulitis, I told you about the hernia. These things all would cause a mechanical obstruction. This can be critical, okay? The paralytic ileus is not to say it's not serious, but it's not going to be life-threatening initially as a mechanical obstruction. If the bowel is completely obstructed, that's a surgical emergency. The functional obstruction, like I said before, is just, your bowels went to sleep. And these are all different reasons why your bowels could go to sleep, whether it's anesthesia or opiates or drugs, whether it's inflammation, but also inflammation could also cause a mechanical obstruction if it's due to swelling. Autonomic nervous system, again, when we talk about neurological stuff later, like brain disorders, problems with the spinal cord. Your autonomic nervous system is the part of your nervous system that tells the body to do, what am I trying to say? They're automatic, you know, like breathing, moving your bowels. You're not telling your lungs expand, deflate, expand, deflate, expand, deflate. No, your brain is telling, your brain's taking care of that. Your autonomic nervous system is taking care of that. You're not telling your bowels contract, relax, contract, relax, contract, relax. No, your brain is telling, sending that signal. So if there is any damage to the brain or to the nerves themselves, to the neurotransmitters like acetylcholine. That's why anticholinergic drugs cause constipation. If there is any type of damage along the nervous system, or if you have a straight like chunk missing out of your spinal cord and those nerves have been severed, it's going to cause issues with the bowels. Okay. Shock, if there's no blood flow to the bowels, you know, when you're in shock and your blood pressure is extremely low, the thing about that is your body, you have that fight or flight response. Your body is going to clamp down, and it is only going to preserve cardiac output for the most vital organs. And if you think about your all the organs you have, your heart, your lungs, your brain, intestines is probably down lower on the totem pole. So when you're in shock, when your blood pressure is low, it can lead to no blood flow to the bowel. You had a patient with ischemic bowel. Okay. And why did they have the ischemic bowel? Was it from like a incarcerated hernia, or was it from shock? Do you know? Jenny Jen? It was from shock. Okay, yeah. So if they didn't have blood flow, yep, she coded on you. Yep. So yeah, if a patient's gone into cardiac arrest, whatever the reason may be, if they're in shock and there's not enough blood flow, certain organs, your body is going to figure out what is priority. And right now, I don't need to worry about pooping. I just need to worry about not having brain damage, breathing, and pumping this heart. Everything else can wait. Kidneys, all that. Everything else can wait right now. So that's what happens with shock. And you'll talk about that next semester. Intussusception. This is mostly, I mean, it can happen to anybody, but it's very rare in adults, right? This is in your PEDS book. Intussusception can also cause bowel obstruction. What happens? It's like your bowels are folding up like a telescope. Um, so it is most likely to occur right here where the small intestine, the ileum, is meeting the large intestine at what? This area is called the cecum. The area, the sphincter or whatever that divides them is the ileocecal valve, right? So what happens is that piece of bowel gets pushed up into that larger piece of bowel, and it causes inflammation, it causes obstruction, it causes a lot of pain for babies. So you see here, here's the real, I mean, this is or not animation cart, I don't know, a drawing, whatever you want to call it. And here's what it really looks like in a real bowel, right? So, and again, I apologize for the graphic pictures, but for me, you guys are getting very limited patient exposure. So it's one thing to tell you about coffee ground emesis, but it's another thing to actually see it. Okay, now I know what it looks like. So here you have bloody jelly-like stool. Remember, blood in the stool can look different ways. Think about anatomy again. Look at where this is occurring. It's occurring all the way at the beginning of the large bowel, right? All the way up in the small intestine almost. So because of that, you're not going to see bright red blood because it's had to travel all the way through the large intestine. It's going to be more black or dark, very dark, and a jelly-like consistency. So they refer to that as current jelly. That's what intussusception. They may also have a sausage, like, you know, because babies and little kids are so small, you may actually see a soft sausage shaped mass in the right upper quadrant, because that's where those, you know, it's going to get pushed up the pressure, and that's where this issue is occurring. Most honestly, most abdominal issues in the up, like the pancreas, the gallbladder, drawing the knees up is going to make the patient more comfortable. The fetal position, any position that brings the knees closer to the chest is going to relieve pain for many patients, for many different GI disorders. Babies and small children, we try to reserve radiation, only as absolutely necessary. You don't want to do x-rays and cat scans on babies and small children, um, while their bodies are developing, because we already know the side effects of exposure to radiation. So for babies, even with like a dislocated hip, the mainstay, the first line screening is usually ultrasound. It's very rare that you're going to order an x-ray or a CAT scan on a baby. Okay. They use ultrasound for everything with kids, small babies and kids. Now, that doesn't mean, oh my God, your kid had an x-ray. Don't get to thinking about your life experiences and everything. I'm just telling you what's textbook. I'm not telling you, this is what's going to happen every single time you go to an emergency room. Treatment is going to be, they're going to give them a forceful enema under ultrasound or radiology. They're going to give them, it'll either be hydrostatic, so high pressure water, or air. But basically, they're going to push that in, forcefully into the colon. Sorry, it will be coming down this way, right? So they're going to force that into the large intestine and hope that they're able to shoot this back out. Does everybody get that? That's the enema. Of course, because they're doing that, if they don't do surgery, there is a likeliness that this will recur, because now that area is probably a little stretched out, so it's easy for it to recur again. So if they had the enema, you want to monitor their stools and monitor them, make sure they're not having signs and symptoms of intussusception again. And then the other thing is surgery. um so so that was just another way that the bowels could be obstructed, right? No matter what the obstruction, the symptoms, a lot of them are pretty much the same, except for these on the bottom, and I'll get to that. Oops. Oh God. So again, think about anatomy. What area of the stomach is hurting? If it's on the right side, you may be more concerned about small bowel, versus if it's on the left side, it probably is in the large intestine, right? Nausea, vomiting can occur with any bowel obstruction, abdominal distension, anorexia, meaning they're refusing to eat. They could have a fever if they have an infection. They may have high pitched bowel sounds above the obstruction. And then no bowel sounds beyond the obstruction, right? There's no action going on. So that's what any bowel obstruction. Now, if it's a small bowel obstruction, if you think about the function, remember, what did I say? All the absorption of nutrients and everything comes in the small intestine. So because of that, you're going to have a more severe fluid and electrolyte imbalance. They're going to have no bowel movement, because the food isn't even going to reach the large intestine to have a bowel movement. So there will be zero bowel movements. There will be zero passing of gas. Okay. And they may actually have more vomiting, more violent episodes of vomiting. It may be projectile. They may actually be vomiting something that appears and smells like stool, because that waste product, the end product, after it's gone through the small intestine, it hasn't gone to you're not able to pass the stool through the large bowel. So they may actually vomit fecal matter. They're going to be restless. These people, when you see somebody like this, you're going to know it, okay? And they're going to be diaphoretic, sweating. They're going to look distressed, and they're going to need emergent surgery if they have a complete bowel obstruction. Large bowel, on the other hand, because of the things that cause large bowels obstruction, And the location, for one, the fluid and electrolyte imbalance is not going to be real serious because those nutrients and everything has already been absorbed in the small bowel, right? So now we're down in the large bowel. However, and don't worry about alkalosis and acidosis. We'll be talking about that in 2 weeks. But because of the location, again, they may have lower abdominal distension. They may or may not have vomiting, and they may actually even have a little bit of stool able to slip around the obstruction. So it may be watery stool, like if they have just a fecal impaction, you know, water may be able to slip past it, or even a polyp or a tumor, you know, a thin, you may see a weird shape to their urine, like it had to thin out and stretch out, but I mean, not urine, stool, sorry. It had to thin out and stretch past that impaction or whatever. So you may see a ribbon-like stool. No matter what the cause, no matter what the cause, the seriousness, the thing you're trying to prevent is going to be bowel perforation. This right here is a perforation. Your bowels, think of it like a balloon. If they just keep filling up, eventually it's gonna pop. Okay, it's gonna have to escape. So perforation is a serious emergency. A person can die in a matter of hours with a bowel perforation. Okay, so we need to know why, you know, this is why hernias, this is why intussusception, these are why these things are important. Maybe a hernia is painless and everything now, but we still want to monitor it to make sure they don't get to the level of obstruction. Maybe they just have a fecal impaction and it's not really anything serious, but please know that if that fecal impaction isn't taken care of and it leads to a serious obstruction, eventually it can lead to perforation and it can lead to bowel death, like Jenny was saying, necrotic bowel, so or ischemic bowel, same thing. Okay, so that's this. This could have been, I don't know if this was a volvulus and it twisted like this, or if it was actually a hernia. But either way, you see blood flow was cut off, and now this part of bowel died. Okay, same here. This part of the bowel has died. Okay, so because of that, it's going to cause, it's going to release gases. It's going to cause a lot of problems, put the patient at significant risk for perforation and significant risk for sepsis, shock, death. Okay. If someone has a perforated bowel, best believe they're going to the ICU. They're going to have surgery and they're going to the ICU. So here's that. Here you see how intussusception could even cause the bowel death. Okay. Diagnostic procedures. I mean, you could do an X-ray. It may be seen on X-ray. It may be seen doing an upper GI endoscopy. It may be seen doing a lower colonoscopy. You know, it just depends on where the obstruction is and what's causing it. You know, you may see a paralytic ileus. You may see that the bowels are full of air or stool, but there's no obvious blockage. That is what leads doctors to say, okay, they have a paralytic ileus. Remember, you're not going to school to be a doctor, so you don't really need to know how to read an X-ray, how to read a CAT scan. Nobody's, you know, most doctors aren't going to come to the RN and say, hey, what did the X-ray show? Unless you have a report typed up, written out by a radiologist. It is not your duty to know the ins and outs of what's on an X-ray. So you don't need to worry about that. All you need to know, like for example, CAT scan. You're never, I mean, unless you go to school for radiology, you're probably not gonna know how to read a CAT scan. What you do need to know as a nurse is monitoring their IV site. You need to know that IV contrast requires renal function. So if someone has poor renal function, you're not going to give them IV contrast. You need to know their BUN and creatinine before they receive IV contrast. After they receive IV contrast, you need to encourage fluids to flush it out of their system. If they're allergic to obviously if they're allergic to IV contrast, but if they're allergic to iodine or shellfish, that could mean they're allergic to IV dye. If they're allergic to one of these, we don't give them IV dye. Now, again, there's always going to be a time where we have no choice and we need a CAT scan. And if that were the case, just remember immunity, they will be getting a prep of Benadryl and steroids to prevent anaphylaxis. So if you absolutely had to give someone something they're allergic to, like IV dye, again, you have to run the risk versus benefit. What is the benefit of getting this test? Does the benefit of getting this test, like, is this test going to help me determine does this patient have cancer or not? What is the benefit versus the risk? What is the risk to the patient? So is it more important to know they have cancer, or is it more important than to just guess because they have an allergy? You get what I'm saying? But anyway, these are things you need to consider when you're doing a CAT scan, okay? IV dye when given with metformin. These are all standard for knowing IV dye. Metformin and IV dye mixed together can cause lactic acidosis. So because of that, and that is also because of the issues it causes with the kidneys, you must hold, anyone who's taking metformin for diabetes, it must be held for 48 hours. That is standard. These are not things that just come out of your ATI book. This is anywhere you work in the world. Here's just some labs. Again, you're going to look and see if they have anemia, dehydration, but there's no lab that's going to diagnose a bowel obstruction. The reason you get these labs is to monitor mostly dehydration, fluids and electrolytes, and renal function if you're giving them IV dye. And then coags like PT, PTT, and INR, you would use for surgery. If someone's going for surgery, they need to make sure their blood isn't too thin. Colonoscopy. The prep for a colonoscopy is geared towards clearing out the bowels. I need their bowels to be emptied so that we can see with the camera, right? There's a colonoscopy that looks at the entire colon. And if you see the picture in the background, the yellow line, that's a colonoscopy versus the blue line is a sigmoidoscopy. It's only going as far as the sigmoid colon. I'm just showing you that, but that's not critical to know. What you need to know is, one, you're going to have to prep them. They're going to be drinking some form of laxative. It really depends on the doctor. Lots of times it's usually polyethylene glycol, which is Miralax mixed with Gatorade. So with that, I'm back in, when I first started, when I first started nursing, they used Go Lightly for everybody. But now they seem to mostly use the polyethylene glycol and Gatorade. But if you work, if you work at an old school hospital or your doctor is old school, then they are going to use Go Lightly. Either way, when for the purpose of your exam and just in general patient education, like I said, remember, any medicine that's going to cause diarrhea is going to cause symptoms of diarrhea. So if someone's telling you, oh, I'm having abdominal cramping after drinking my Go Lightly, well, that's kind of normal. That's expected when you're drinking Go Lightly, okay? Because you're having diarrhea. So just know the prep, and you want to know the same as a EGD. I mean, it's the exact same. Knowing management with sedation, with the conscious sedation. Anytime you're doing an invasive procedure, you're holding any meds that could promote bleeding. So NSAIDs, aspirin, anticoagulants, those things are going to put the patient at high risk for bleeding. For this one and EGD, know the positioning for the two procedures. Now, just like with the upper GI, the EGD that we talked about last week, same with the colonoscopy, there's risks to every procedure. We're going in your bowel with a tube. There is a risk that I could perforate your bowel. I actually sadly had a patient that went for a colonoscopy and ended up in the ICU Actually, I've seen it a couple times with perforated bowel. Okay, it can happen. It's one of those papers the person signs before they go under for the procedure. Is they know, they're acknowledging there is a risk that that camera, that scope could perforate their bowels. So you're gonna monitor for any signs of perforation. Now, again, these are just more graphic pictures to get your mind, thinking about. I don't want to just talk to you about stuff. I want you to imagine. So say, this is what a normal inside of your colon looks like. So now you could see, obviously, if you had a tumor of some sort, that's going to obstruct the flow. But also think about if these areas were swollen, edematous from inflammation and infection, if they're super swollen, it could essentially cut off the flow. And then these are just different polyps you would see. Now, the next slide is this video, right? You're going to watch this on your own. I'm not going to watch that for sake of time, but it's going to show you about the procedure. I believe I put already a video on Moodle. It's going to show you about the prep. These videos are so perfect for seeing what the real patient experience is like, because obviously our clinical experiences right now are so limited. We talked about NG tubes a little bit last week, but not really. So with a bowel obstruction, with a GI bleed, with many different GI issues, you're going to consider inserting a nasogastric tube. The NG tube can be inserted to remove gastric contents, because obviously if there's a blockage down here, then we want to remove gastric contents. You'll see later also, if you have gallbladder disease, if you have pancreas, acute pancreatitis, those organs produce the bile and other enzymes for digestion. So by having food in your stomach is going to make those organs move. So and cause even more pain and inflammation. So you may need an NG tube for that, to empty the gastric contents. The other thing the NG tube is doing is it is removing air. It is removing air, decompressing the bowel. Because even if you don't eat and even if your stomach's empty, just think you're still passing gas all the time. But if you already have an obstruction, again, that balloon is filling up with air and eventually could burst. So an NG tube is going to decompress the bowel as well. Obviously, if someone's got an NG tube, they're going to be NPO. Why would I be eating and drinking when I have a tube going down my esophagus and the tube is in there to empty it out? If they have a bowel obstruction, they're going to be NPO if there's no way for the food to escape. You're going to monitor labs. You're going to maintain the NG. And when anyone has any type of tube, whether it's NG, whether it's OG, whether they're on a ventilator and they're intubated, oral care must be performed. It prevents infection. It's just, you need to perform oral care. Prevents infection, prevents further complications. Okay. So again, with the NG tube, these are the different types that you could use. If you are using it for suction, if you're suctioning out gastric contents, if you're suctioning out blood, if you're suctioning, you want a large bore. Large bore means it's bigger, it's wider, it's a bigger circumference. Versus if it's just a feeding tube, then it could be a thinner single lumen small bore. It can be thinner because all we're doing is just pouring liquid down. And gastric lavage would be like if you ingested poison or if you had alcohol poisoning or something like that. They may insert in an emergency, insert a tube, an oral gastro tube or an NG, and dump in stuff like charcoal to get you to promote vomiting and flush that out of your system. That will be a gastric lavage. Contraindications to inserting the tube will be any facial trauma. Obviously, if they have a broken nose or a whole bunch of swelling, they got hit in the face with a baseball bat, you're probably going to be a little leery about inserting a tube that could essentially cause more harm to the patient. Also, if they have a hole in their esophagus, any type of perforation, you're not going to want to insert an NG tube, okay? I sent you the skills checklist is in Moodle. There's a video, I believe, in Moodle as well. I recommended if you wanted, if you needed ideas on how you're going to spend your 2 hours in ATI, there were modules that you could do as far as NG tubes that go into more details than your book actually does. But either way, once it's inserted, you're going to confirm placement with an X-ray. It is so easy. When you're putting this tube in, it is extremely easy for it to slip down into the trachea and all the way to the right main bronchus, okay? So if you put it in the lung, you're gonna see the patient turning blue, coughing, gasping for air, okay? You don't wanna kill somebody, so we got to, and then you definitely don't wanna be connecting it to suction or dumping anything in the tube if you haven't confirmed that the tube is not in the person's lungs or their trachea. So you must do an x-ray initially. Once the x-ray is confirmed, you've measured, it's taped in place, you don't need an x-ray every single day, but you do need to confirm placement every time you use this. So at the beginning of your shift and you're coming on and your patient has a tube, you need to confirm placement. You can confirm placement by auscultating. That means you'll see in one of these videos, they inflate the syringe with air and force it into the NG tube and then listen to the belly for gurgling. You should be able to hear the bubbling in the stomach. However, the more accurate test is going to be to actually aspirate, draw back on your syringe and pull back gastric contents and check the pH. In my 12 years, I don't know, maybe Carly's mom's seen this, but I've never checked anyone's gastric pH, okay? But for the sake of textbook, this is the end. I mean, in all actuality, checking the gastric content is going to be much more accurate. But, you'll find when you get in practice, most people are just doing auscultation. But again, for your test, don't think about what you see at work because it'll get you messed up. Think about what is the textbook way to do things. By the book, by the rules. So, not going to play the videos, but I love these videos are so good for somebody. If you've never done this and you've never seen it, I don't think it does you any justice seeing it done to a dummy. I would rather you see it done to a human being. So this first video, you watch it on your own. All these videos are 5 minutes or less. But this first video is the proper way to insert an NG tube, okay? They did a great job showing you how to set it up and everything. This next video, okay? They really thought they were doing something. I give them an A for effort. But if you really don't listen to what they're saying, because in their video, they really think they're doing it. They're doing a great job. But if you really watch, first of all, you're going to see one, the patient is laying completely flat the whole time they're putting the NG tube in. No, heck no. Why would you put anything in anybody's mouth, nose? Why don't you do that while they're laying flat? So that was the first thing, red flag. You're going to look at this man's coloring. The man is Caucasian, maybe he has a little tan, but by the end, when they're like, oh, we put it in the right place, the man's face is purple, okay? So you'll see the changes. You also see at some point, she puts the NG tube in his nose and it comes out of his mouth, okay? But again, don't listen to what the video is saying because they're telling you they're doing a phenomenal job in this video. But if you watch it, you're going to see all the complications and what not to do, okay? So that was my purpose of that video. But you know, they tried it. They look, I, I'll be scared if anybody ever saw any of my videos on YouTube. So, anyways, they had the right idea. So, obstruction, again, it could be a surgery. Okay. Surgery could be removal. You know, they've done a resection where they just remove. Resection means you're removing a part of it. So resection, where they took this piece of bowel out, and then they either took the ends that were left and connected them. That would be a, I'm sorry, that would be a colon resection. Or do they take one of the ends and create a colostomy or ileostomy? So it really just depends on what the cause of the obstruction is. Exploratory laparotomy, that's usually like you as the nurse, that's what you're going to see them say. Oh, the doctor is going to say, I need you to get a consent for exploratory lap with lysis of adhesions. Or if they're going in and they have no clue what's in there, they may say this, oh, get an exploratory lap, you know, lap short for laparotomy, exploratory lap with possible lysis of adhesions, possible colon resection, possible colostomy creation. That may be exactly what it says because they have no clue what they're doing. They're just going to do the exploratory laparotomy, meaning make an incision in the abdomen and explore. They're going to look around and they'll figure it out when they get in there what is the best surgical intervention. So do you need to know the ins and outs? No. You just need to know as a nurse, how do I provide care to a person that just had abdominal surgery? How do I provide care? What are the biggest complications? What are my priority assessments? That's what you need to know. You don't need to know every single surgery and what it is. You're not a surgeon. I'm not a surgeon. You just need to know as a nurse, what is my responsibility? So colostomy and ileostomies. First of all, the ending ostomy just means hole, okay? There is a surgical opening from the inside to the outside of the body, right? So you could have a tracheostomy, right? A hole in your throat. There's other ostomies. You could have a gastrostomy tube. That's the feeding tube. They made a hole to insert a tube into your stomach. But for this exam, we're not going to talk about TPN and tube feedings for this exam. For this exam, though, you do need to know about ostomy care. Knowing this is a stoma, okay? An ileostomy is just that. It's an ostomy created in the ileum, right? If they have Crohn's, if they had an issue that caused severe damage to the whole large intestine and there's no recovery and they just need the whole large intestine removed, then they will get an ileostomy. If you know where the ileum is and what happens in the small bowel, then you would have an idea of what the stool, first you would know where the location, it's always going to be in the right lower quadrant because that's where the ileum is, right? Also, because it hasn't reached the large intestine, the stool is going to be watery. It's going to be very liquidy. It's not going to be formed as in a colostomy, sorry. A colostomy is any of those creations along the large bowel, okay? So it could be on the left, it could be on the right. It just depends on what area was affected and where they did the surgery. A colostomy can be reversed. Not always. It's sometimes they make temporary colostomies, sometimes they make permanent. But an ileostomy, they have removed completely your entire bowel. So, I mean, your entire large bowel. There's no reversing that. They don't put it in a jar and put it on a shelf and save it to put back in you. However, if they just did a resection, they could essentially, when the swelling and inflammation from the surgery and whatever happened that caused the surgery in the first place, when that goes down, they could essentially go back, bring this stoma back inside and connect it back to what was left of the bowel. Does everybody understand that? So with this, your job as a nurse is going to be education. You're going to educate. Obviously, this patient isn't, I mean, they can live a normal life. I had a friend, her boyfriend was shot in the abdomen. He had a colostomy. He went to work. There was, and it eventually got reversed. But you can live a normal life. So you need to teach this patient how to take care of their colostomy, because they're only going to be in the hospital a few days and maybe get home care for a couple weeks, and then that's it. This is your life. You need to become comfortable with this and learn about, how to take care of it. What are signs that the stoma is not doing well? So this right here is called stoma, the stoma. Okay, this is the actual where the hole is. Okay. um for a tracheostomy, the stoma is just the hole. You're not bringing a piece of the organ out. But for the colostomy and the ileostomy, the stoma has a piece of intestine there, a piece of bowel. So you need to monitor this and make sure that that intestinal stoma is pink and moist. It may be a little bloody at first because they just had surgery. It's not uncommon to have a little bit of bloody drainage. Um, but if it's 10 weeks after surgery and they're bleeding, that could be a complication. You want to monitor the skin around it. Is the skin intact? Remember, you're especially the ileostomy. Ileostomy, because think about it, you got bile and stuff with that, or even worse, if you have a jejunostomy, which is higher up in the small, because of the bile, that can cause burns to the skin. Okay, especially a jejunostomy can cause burns to the skin. Liquid alone could cause maceration, which is like water down. It's, if you had your hands submerged in water, your skin eventually gets wrinkled up. But if you stayed in that water like a dead body, eventually that skin is like sloughing off and maceration. So monitor the skin, monitor the stoma. If this stoma is purple, if it's gray, if it's losing color, those are signs that something is going wrong. A lot of times what can happen, a complication will be that this dies. This piece of bowel, for whatever reason, doesn't survive. It doesn't get good circulation. It doesn't heal well. And now it's dead. Again, remember, any dead tissue is going to lead to sepsis. It's going to cause serious problems in your body. So if you have a dead piece of intestine, and it's going to cause further death of the tissue, that death is just going to travel, and more of the intestine is going to die. And that could lead to death of the patient. So if it's gray or purple, you need to notify the surgeon. You need to, understand that the patient may need to go back to surgery and have that revised again, a revision, have a piece of it removed. They're gonna need a referral usually to an ostomy nurse if it's a new colostomy. Now, if you had a colostomy for 10 years, you probably don't need a special care nurse, but a new colostomy, they're gonna need a lot of support at first. They're going to need psychosocial support, no matter what the age is. Who wants a bag of stool hanging off their stomach up under their clothes? No one. It doesn't matter if they're old, it doesn't matter if they're young. They are going to have serious body image issues. And people become very depressed when they have stuff like this happen to them. So they need psychosocial support, and of course, always hydration status. This, again, very graphic, because it does actually show a real ileostomy, the real stool and everything. But again, I cannot stress to you, like, these videos are so perfect at showing you exactly what you would do as a nurse. So I'm not going to show it because it's too much. We don't have a lot of time to do all that, but you can watch them. Everybody has the PowerPoint. Uh, Inflammatory. Now we're moving on. Inflammatory bowel disease. So without me even telling you anything, these are autoimmune diseases, okay? These are autoimmune, these are hyperinflammatory disorders. So what am I going to use to treat inflammatory bowel disease? What medications would you use? It's okay to guess. I won't make fun of you if you're wrong.
Steroids?
NSAIDs?
Steroids, yes. NSAIDs, not so much. Steroids, because not the NSAIDs, because you know you don't want them to have a bleed. But steroids steroids and even immune suppressant drugs. Those are the treatments for methotrexate, prednisone. Yes. Okay, we're learning. We're learning. So now this goes back to last exam, last chapters. You got to know, you're going to need to know about inflammation throughout every system. But you see, I couldn't be teaching about rheumatoid arthritis, Crohn's disease, vaginitis, inflammation. No, we go system by system. But now that you understand what happens with inflammation, now you're going to understand as we go through the systems what can happen, or what, and the common treatment. No matter what part of the body, the treatments are kind of the same. So Crohn's and ulcerative colitis are considered autoimmune in nature. It can affect, for Crohn's, it can affect anywhere from the mouth, from the rooter to the tutor, like my old lady friend used to say, from the rooter to the tutor, okay? It can affect any part of the GI tract. It also extends through all layers of the tissue. Unlike ulcerative colitis, which we'll talk about next, only affects the lining, Crohn's disease can eat through and cause damage to the entire intestine. So because of that, they have what's called fistula formation. A fistula is a connection that shouldn't be occurring. It is a connection between two body parts that is not supposed to be there. So when you have this Crohn's disease just riddling through all layers of your intestine, then what happens is it can start to form like a tunneling. So for an example, a person can have what do they call it, an anal vesicle fistula, and I may be saying that wrong, but they can have a connection between the anus and the vagina and actually experience stool coming out of the vagina. That is an abnormal connection. That is a fistula. So you don't ever want to see feces coming out of the vagina. If you did, then you know this person has a fistula formation. There is a weird connection somewhere to the bowels and it's coming out of the vagina. That fistula can form anywhere, but that was just the best example I could give you of a fistula formation. Crohn's, unlike ulcerative colitis, has no bleeding. Now, never say never. You know, I don't want you to go to the hospital. You have a patient with Crohn's disease, and then you see blood in your stool, and you're like, hey, you don't have Crohn's disease. Okay, never say never. But for textbook purposes, ulcerative colitis is associated with bloody stools. And I'll get to that in a second, but Crohn's is not. Because Crohn's, usually, even though it can affect anywhere, it tends to affect the small bowel most commonly, okay? And because, yeah, right here, the small bowel, because it's affecting the small bowel, they're gonna have more issues with malabsorption. They're gonna have a lot of vitamin deficiencies. And they're going to, what was the other thing I was gonna say? I guess that was really it. They're going to have, they're going to be the ones too that a lot of times end up with the ileostomy, but they're going to have a lot of issues with malnutrition because of the area that's affected, right? Remember, small intestines is responsible for absorption of nutrients. So if your small intestines are damaged in some way, then you're not going to be able to absorb all the nutrients you need. So because, okay, so diagnosis, I'm sorry, you could look on an x-ray and they have a classic sign, string sign is something you may see. Another thing is the cobblestone appearance, which occurs because all the different layers, it's being affected all throughout your your intestine at different layers. And I'll show you a picture next. Colonoscopy, you're gonna wanna do. Now, times when you don't wanna do a colonoscopy would be if the colon is severely inflamed at that time, you're not going to do a colonoscopy. If they have edema and swelling in the colon, you're not going to do a colonoscopy. Why would you do that? It's already inflamed. It's already irritated. Now you're going to shove a tube, a camera up in there. Yeah, I'm sure that'll make the swelling go down. No. So if there's severe inflammation, also, if there is a risk of rupturing something, like if the patient has an abscess, and that's a complication of Crohn's, an abscess, think of an abscess. A layman's term would be a boil. Is everyone aware? It's more than just a pimple. It's like a boil, okay? But you have a boil inside your intestine, basically. That's an abscess, okay? Huge pus collection.
It can pop, right? Like an abscess can
Right,
just pop.
it can pop. So if you put the colonoscopy, if you do a colonoscopy on someone who has an abscess and that abscess ruptures, you're putting them, one, you got all that pus leading, I'm using layman's terms to help you understand. Pus, exudate, infectious material, whatever you want to call it. I'm calling it pus. You got all that pus leaking into the abdominal cavity. So they're going to be at extreme risk for sepsis and peritonitis. Or if it's an abscess like affecting the layers of the intestine, you could have essentially just popped and ruptured their intestines. And again, peritonitis and a very rapid death. This is a critical emergency. So with that, just like any other autoimmune disorder, you really need to monitor ESR and CRP, right? Because they are inflammatory markers. In Crohn's or ulcerative colitis, those would be elevated. In lupus, in anything that's causing systemic inflammation is going to cause these to elevate, okay? Now, because of the malabsorption, the main vitamin that people with Crohn's are lacking is vitamin B12. Vitamin B12 deficiency leads to anemia, pernicious anemia. Pernicious anemia is a common complication of Crohn's. So you need to watch their H&H, hemoglobin and hematocrit, or CBC, because the CBC contains the hemoglobin and hematocrit. You need to watch your red blood cells, the red blood cell count, and you need to monitor their vitamin B12 levels. People with Crohn's, a lot of them need injectable B12. Why? Because giving them a B12 pill isn't going to help because it needs to be absorbed in the GI tract, right? So they usually need vitamin B12 injections to prevent pernicious anemia. So both Crohn's and ulcerative colitis cause anemia, but they cause two different types of anemia. And I'll talk about the UC in a second. Dietary, again, I can't stress enough, you need to know the different diets for these disorders for your exam and for your nursing career. You need to know how to educate these patients. Smoking is going with smoking makes everything worse. But with these autoimmune disorders, because smoking also causes inflammation, it really complicates the disease. So if you have Crohn's and you smoke cigarettes, you're probably going to have more frequent acute exacerbations. See, Crohn's may not be chronic pain. They're not always having pain. If their disease is well managed and they're taking their meds, these meds down here, they may not have chronic pain and diarrhea, but they will have, it's what they call relapsing remitting disease. A lot of diseases are like that, relapsing remitting, where they have a relapse or an exacerbation or a flare up, but then it may go back down. If you're taking immune modulators and your immune system's in check, then it may go back down and be in remission again. It may, be cool. It's not flaring up. Doing the right thing, not smoking, eating the right diet, and taking your meds is going to prevent flare-ups. You don't have to end up with an ileostomy, but not taking care of yourself is going to put you at higher risk for that, right? Corticosteroids, we already talked about that. Immune suppressants, we already talked about that. Metronidazole, also known as Flagyl. Flagyl is usually the most common antibiotic used to treat intestinal and vaginal infections, diverticulitis, the list goes on and on. But metronidazole is used with Crohn's to treat bacterial overgrowth that they may have. And these 5 ASAs, one of the drugs is mesmeline. Mesmeline is used commonly also to decrease inflammation in the small intestine. So you don't usually need that for ulcerative colitis, because ulcerative colitis more affects the large intestine. But anybody that has inflammation of the small intestine, those drugs can help. Crohn's, again, I already told you, complications because of the edema, or if they had an abscess, it could cause obstruction. Abscess alone is, that's increasing risk for obstruction and perforation and sepsis and everything else. Fistulas, we talked about that. Malabsorption, again, the small intestine is being affected, so it's going to affect the absorption of nutrients. And I cannot stress enough the vitamin B12 deficiency and pernicious anemia. That is why people are anemic with Crohn's. Surgery may be an option. The medications we talked about may be an option. TPN if they need bowel rest. We will talk about TPN next week when we talk about fluids and electrolytes. But total parenteral means IV. Parenteral means IV. So this is different than IV fluids. These are IV fluids with nutrients, fats, everything added to it. So they're big bags. They are white. They usually look white or yellowish in color, and depend on what nutrients are added, but they have like basically the nutrition you would get from eating food added to them. IV fluids is just that, IV fluids, okay? But we'll talk, I won't test you on TPN this upcoming exam. Okay, moving on. Ulcerative colitis. Like I said, ulcerative colitis tends to affect the sigmoid colon or the large intestine. It does not affect usually the small intestine. It's usually down here. So because of that, they don't have the malabsorption issues that people with Crohn's have. Like usually people with Crohn's you'll see are thin. They look thin, they look malnourished, they look sick. They look, if someone has Crohn's, not all of them, but a lot of them because of the malnutrition. Whereas ulcerative colitis, they may be obese and still have ulcerative colitis. It's a lot less likely to see an obese person with Crohn's. And that is because they're still able to absorb all their nutrients in the small bowel. They're just having issues with stools, and it is what it says it is, ulcerative. There is ulcerations forming in the colon. Why? Because it only affects the superficial lining. It does not eat through all layers of the intestines like Crohn's does. It only affects the superficial mucosal lining, and therefore it causes erosion and it causes bleeding. So that is why ulcerative colitis, you will see bleeding. Because of that bleeding, the patient could have anemia. So anemia and ulcerative colitis is going to be related to chronic blood loss. It's not going to be related to pernicious anemia that occurs with Crohn's. Again, remember the sides, okay? If it has to do with the large intestine, most specifically the sigmoid colon or the rectum, it's going to be on the left side versus the small intestines, the ileum, things like that are going to be on the right side, because this is a cecum right here. That's the start of the large intestine, and behind it is where that ileum is coming and connecting. So you see right lower quadrant versus left lower quadrant. This is thought to be due to diet, and because the United States has probably the worst diet in the world, it's going to be more common here in the United States. Other countries tend to eat more fresh vegetables and get more fiber in their diet. Meanwhile, we're eating Macho Man TV dinners. So it's much more common in the United States. Likely could be due to a low fiber diet. But these are the manifestations, and then as far as complications. So again, colon, you don't need to know about cancer because we'll talk about cancer when we get to cancer, but colon cancer, colon means large intestine, colon cancer. Ulcerative colitis affects the colon. Chronic inflammation and irritation leads to cancer. Therefore, ulcerative colitis is going to put the patient at high risk for colon cancer versus because now Crohn's is going to put you at risk for a lot of other issues, but not as much colon cancer because it usually isn't affecting the colon. It's usually affecting the small intestine. Okay. Again, the chronic anemia is due to blood loss versus pernicious anemia that occurs in Crohn's. And then of course, perforation. Anytime you have inflammation and constipation or any problem, you want to worry about perforating the bowel, obstructing and perforating the bowel. And of course, abscess. You don't want an abscess to form because it could lead to perforation of the bowel. And then here, medications are pretty much the same as Crohn's. And then the dietary stuff. Anybody have questions thus far? We're doing okay. We understand. Again, don't worry about cancer. Don't worry about tube feedings and don't worry about TPN for the upcoming exam. Right now, I want you to understand how the GI system works and what type of things could affect the GI system. These diseases I'm talking about today are diseases you are going to see commonly in the hospital, no matter what floor you work on, okay? You're gonna come across these patients. Whereas, like I said, fibromyalgia, I don't know why Lippincott chose fibromyalgia. You're not going to have somebody hospitalized for fibromyalgia. So I'm not going to spend a week talking to you about fibromyalgia, okay? I'm going to talk to you. You're being trained to be a registered nurse. The idea is that most of you are going to go on to work in the acute care setting in the hospital. We are not training. I mean, not to say you can't work outpatient, but primary care is primarily reserved. You don't really need an RN in primary care. Nurse practitioners learn about outpatient primary care. And they work with usually either an LPN or even just medical assistants. The RN, the role of the RN is primarily found in acute care. So therefore, we're talking about acute processes. Diverticulitis is an acute inflammation of the diverticula. Diverticula or diverticulum are these pockets right here. So remember what a normal colon looked like? Now you see this one. It looks pretty normal, except you got all these little, what the heck are these? These are little pockets. Those are diverticula. This is an image of diverticulosis. Diverticulosis is just the presence of pockets versus itis. Anything that ends in itis has to do with inflammation. So having diverticulosis alone is not, they're not going to be hospitalized. Usually when you find diverticulitis or losis, it's because the patient had their routine colonoscopy or they had a CAT scan for some other reason, and then you saw that they had diverticulosis. But just having the pockets alone is not going to cause any symptoms. However, you do need to teach these people about dietary choices before they end up with diverticulitis, and we'll talk about that in a second. Diverticulitis, usually it can affect any part of the colon. However, it normally affects the end, the rectosigmoid colon. So it's going to have left lower quadrant pain. Now, I have seen a patient with, diverticulosis in the cecum, which is over on the right side, and diverticulitis there. But rarely, that is very rare. Normally, when you have a patient, it's going to be the rectosigmoid colon or the sigmoid colon being affected, and the pain is usually always in the left lower quadrant. That's usually hallmark. Left lower quadrant pain. They may have a low-grade fever, possible blood in the stool from irritation, but it's usually left lower quadrant pain, fever, and nausea and vomiting, and maybe diarrhea, okay? It's gonna be diagnosed by looking at a CAT scan. They're gonna get a CAT scan, and that can actually be seen on a CAT scan. And they likely all have elevated white blood cells from infection and inflammation. Again, because you got that inflammation going on there, it's very easy for an abscess to form. That's like the biggest complication with diverticulitis. You don't want the formation of abscess because, again, you don't want a perforation and you don't want sepsis and peritonitis. It's the same. Any issues in the GI tract, in the intestines, these are what you're trying to avoid: perforation, sepsis, peritonitis, abscess. All of those are horrible outcomes for the patient. Diverticulitis, it depends on how serious it is. You may, well, you'll never see them if you're working in the hospital, but people can be treated outpatient. They go to the doctor, they have a left lower quadrant pain, or the doctor even ordered a CAT scan, and it showed us on the CAT scan, and they could get oral antibiotics. So not everyone's going to be hospitalized, but the ones who are more severe, or they have an abscess, or they are like in severe pain, or they can't hold anything down, they're having a lot of vomiting, they're going to be hospitalized, and they're going to require IV antibiotic and IV fluids. Whether they're in the hospital or whether they're at home, clear liquid diet is what's recommended. So they don't need to be NPO because they're not obstructed, right? So they could still move their bowels with diverticulitis. So they don't need to be NPO, but they really don't need to be eating a whole bunch of food either and having to make big bowel movements. So clear liquid diet is the diet for diverticulitis. And then you can advance it once their symptoms resolve. So for the exam, you need to know, what is a clear liquid diet? Again, like I told you before, you're not going to insert a colonoscopy. You're not going to insert a endoscope camera into an area where there's a lot of inflammation and possible abscess, because that's only going to lead to further inflammation, or you could possibly rupture the bowel at that time. You do not do a colonoscopy on someone unless it's a critical emergency and you got to do a colonoscopy to get in there and stop the bleeding or something. There's no indication for endoscopic procedure when there's actual inflammation occurring in the bowel. Now, with any inflammation in the bowel, with diverticulitis, with appendicitis, even though it's not, you'll see, you do not, you need to know this. You do not want to give these people laxatives. You do not want to give them enemas. If the colon is already inflamed and it's swollen and we're already at risk for a rupture, you're not going to give them something that is going to just fill the bowels more, right? If I give someone with a abscess or on their diverticulum, if they have a diverticular abscess, or if they have an abscess on their appendix, which is right hanging off the colon, and now I increase pressure by filling the colon with stool, or God have you putting an enema in there, I'm increasing pressure, I am increasing the risk for rupture. Does everybody understand that? All right, nobody asked a question, moving right along. Nursing considerations is like I just told you: pain meds, nausea meds, IV, antibiotic, clear liquid diet. Advance later when the diverticulitis, when the inflammation and all that has subsided, then you'll want them to be on a high fiber diet and avoiding small, undigestible seeds and little food items like that. Popcorn, corn, nuts, raisins, anything that could get stuck in those pockets. And this is the same teaching, high fiber and avoiding these. You would still give this teaching. Maybe the patient didn't have diverticulitis, but they had the presence of diverticulosis. Diverticula were noted on their CAT scan. You're going to give them the same teaching. You don't want them to get diverticulitis. We're getting there, people. appendicitis, right? So the appendix is this little tube shaped, finger shaped organ hanging off the cecum, right? It is hollow inside like a straw, like the rest of the intestines. And its function, we're not really quite sure about. We know it does have some properties. It holds some of the normal flora bacteria from your gut. We also know that it plays a part in the maturation of those immune cells. But either way, don't worry about that. But what you need to know is what can happen for whatever reason. The appendix likely becomes obstructed or it becomes inflamed, and now you have edema. You could have abscess formation, but that's what's happening with appendicitis. In adults, it's going to be younger adults, but it's also most common in children. Like, so I would even put the range age 10 to 30 because it's usually like pre-adolescents, adolescents, and young adults. Okay. When it becomes inflamed, obviously we do not want we don't want anything in the body to perforate ever. We don't want anything to rupture. Okay. But this infected, inflamed appendix, again, if it ruptures, then we're talking, this is critical. They're going to have peritonitis, that inflammation of the peritoneum. They're going to be at risk for sepsis and ultimately death. So we don't want that. And like I said, because we're not sure what the cause is, and we're not sure what the function exactly is of the appendix, but we do know once it becomes inflamed, if it ruptures, it could kill us. So with that being said, we're just gonna remove it. We're just gonna remove it. That's the only treatment. Cut it out, get it out of here. We don't even know what the thing was doing here in the first place. Symptoms are going to be, it's going to start with pain in the periumbilical region. Umbilicus, umbilical refers to that place where your umbilical cord used to be, your belly button. Belly button's not a medical term, okay? Umbilicus. So periumbilical, whenever you have a patient presenting with periumbilical pain, the concern is always, do they have appendicitis? And then later it's going to go to the right lower quadrant. You need to know this area, McBurney's point. This is McBurney's point in the right lower quadrant. That's usually where the pain is. Rofzig sign would be when you press on a different, no matter what area of the stomach I press on, whether it's right upper, left upper, whatever, the patient experiences pain in the right lower quadrant. So I could be doing percussion way up here and they're having pain way down here. That is Rovsig's sign. And then nausea, vomiting, they could have a fever. Again, the biggest complication is going to be perforation. If that appendix has perforated, now think about this, it's inflamed, it's swollen, it's painful, but then suddenly it bursts. Initially, you're going to have a relief of pain, like, whoo, it was so swollen, it was all that tension, and then poof, it bursts. Whoo, I'm going to have a sudden relief of pain. But quickly, peritonitis is going to develop. You're going to have abdominal distension, tachycardia. They're going to be breathing heavy. The pain's going to return. They're going to have a rigid abdomen. They're going to have a high fever, okay? So the initial relief of pain is going to be a sign that they may have perforated. What diagnostic test? Usually an ultrasound is good enough. They can do an ultrasound and diagnose appendicitis, but a CAT scan could also diagnose it. You don't need to know how to read an ultrasound, but I just wanted to, show you this cool picture. This is again like a drawing of what's going on. And here you go. That's the appendix right there, okay? Once it's been removed. Serious complications, again, the same for everything else. Perforation, peritonitis, sepsis. What's up?
I'm sorry to interrupt. I have a question. When the appendix ruptures, don't they consider that like a medical emergency or that
It's
they
a
have to
yes,
do surgery?
yes. It is an emergency. Again, because how quickly, because peritonitis can kill somebody, okay? When something ruptures, that's the thing. Perforation of the bowel, perforation of appendicitis, of an appendix, emergent. It doesn't matter if it's 2 a.m. You're going to call the surgeon. They need to put their scrubs on. They need to put their shoes on, and they need to bring their butt to work because they got an appendix to take out. And not only that, they need to get that infectious waste out of the abdominal cavity. But either way, appendicitis is usually an emergency either way, because it's so small. This little thing, it's so easy to rupture once it becomes inflamed. So even if it's not ruptured, it's still that patient, the only treatment is send them to surgery. They need to go to surgery. But now, if it hasn't ruptured, may they drag their feet a little bit, maybe 2, 3, 4 hours till surgery, maybe. But if it's ruptured, you need to hurry up. Everybody, all hands on deck, because this patient is going to die if we don't intervene, okay? So IV antibiotics, IV fluids for either one, but surgery is the only treatment. You're never gonna send a patient home with appendicitis.
Are you more likely to get diagnosed with appendicitis after it ruptures, or are you most likely to catch it when you have your first initial symptoms?
You know what? It could, I'm sorry, rupture is going to be much more easily identified because that patient is going to have more exaggerated dramatic symptoms.
Mhm.
So I would think rupture will probably be easier to identify, but I don't know which one honestly is found more often, but appendicitis could go unnoticed, because the symptoms could be vague. You could be having vague right lower quadrant pain. You may not have a fever, nausea, or vomiting. And then the fact that there may be a low grade fever, there may not be. So usually it's probably when that appendix is either at the point where it's about to rupture
Mhm.
or it's already ruptured, where the patient is having severe pain, and that's what brings them to the hospital. So I would think, yeah, probably rupture or right before it ruptures. But either way, once the appendix is inflamed, because it's so tiny, it's easy to rupture. So we got to just cut it out. We don't even know what the thing does in the first place. So post-op care, no matter what the abdominal, and I'll talk about that in a second. Post-op care, it doesn't matter. Abdominal surgery is abdominal surgery, okay? You are going to monitor vital signs of shock, hypotension. You're going to monitor for fever. You're going to monitor airway, breathing, circulation, O2 saturation. Give them supplemental O2 if they need it. That is going to be the same no matter what the surgery. Now, appendicitis, the surgery is going to depend on, is that appendix intact or is it ruptured? If the appendix is intact and it hasn't ruptured, then it's likely just going to be laparoscopic. They can make small incisions and just remove the appendix. If anything in your abdominal cavity ruptures, if your bowel ruptures, if your appendix ruptures, all that infectious waste up under the skin and just floating freely in the abdominal cavity is going to require an open incision, a big incision, and it's going to remain open. We're not going to stitch you back up with all that infectious waste in there. So what you'll find is a patient with an open, maybe they have a midline abdominal incision, they never closed it, and then they have a wound back there. They're gonna keep those incisions, just like if you had a big boil, say you had a boil on your butt or whatever, your underarm, and you went to the ER and they lance it, they put a cut in it, they drain the pus out. They are not going to stitch it back closed because there's still infection in there. It needs to get out. So, and if they were to ever stitch something like that closed, it's going to be very loosely stitched to allow room for that infectious material to seep out. Everybody got that? So that's that. Any abdominal surgery, it can cause paralytic ileus. So you're going to want to monitor bowel function. It's definitely important part of your assessment as a nurse to be listening to bowel sounds on anyone who has had bowel surgery or abdominal surgery. Sorry, abdominal surgery. So that's it with the bowels and intestines. And then now we're just going to talk about liver, gallbladder, and pancreas, and then we're done. Do you guys want to, what time is it? Oh, I could get through this by 12, and then we'll take an hour lunch. Is that good? Yay, nay, or you need lunch?
Yes, that works. I'm cool
That's
with that.
I didn't
wonderful.
know if
Thanks.
anybody was dying and they need lunch.
Yes.
All right, nobody took their
Yes.
insulin and they're gonna fall out. All right. All right, so again, I keep going back to anatomy and physiology because if you don't know what the organ does, you'll never understand inflammation or any other issue of the organ. It will never make sense if you have no idea what this organ is doing or where it's located in the body. So, sorry to be repetitious, but let's go back again. So, we talked about the esophagus. Food is going to travel through the lower esophageal sphincter. And when you have issues there, it will back up, right? And cause GERD. The stomach, you know, you got the fundus up here is the top part, the bottom part is the antrum, and then you have the pyloric region where food travels through here and out the pyloric sphincter, sorry. And then again, if you have an issue here and it's hypertrophied or stuck in place, like pyloric stenosis, again, food's going to back up. Now it's backing up into the stomach, and now you have vomiting, not just regurgitation, but now you have vomiting. Then you get down to the duodenum. You could have peptic ulcer disease, many other things in the duodenum. Now, the duodenum, remember, receives all the bile and the pancreatic enzymes. They are dumped into the duodenum via the common bile duct. So think about it. Anything that is going to cause an issue in this common bile duct can also cause an issue in the gallbladder. It can cause an issue in the liver, and it can cause an issue in the pancreas. Why? Because look at where they're connected. So if I have a blockage here, it's going to back up in every direction. Again, anatomy and physiology, okay? So, as far as the liver, what does the liver do? It does so much. Oh my God, the liver, such a vital organ. Like, I mean, well, yes, it's vital. It's vital to your life. You cannot live without a liver, okay? You can remove one kidney and live, but I cannot remove my liver, or my liver cannot completely shut down and me live. It's not going to happen. You could even get dialysis with your kidneys. Right now, they're still in the process of trying to figure out some way to do dialysis for the liver. So you may hear about that, hepatic dialysis, but that's going to be like at what's your guys' hospital? What is it, Gaines or whatever, the big, huge university type hospitals. It's not going to be something common. The liver is the biggest, largest, heaviest organ. It produces bile, and it breaks down so much of the food you digest and helps to absorb nutrients. Remember, the liver, the blood is coming from the intestinal tract to the liver, and we'll talk about the liver in a second. Yeah, okay. Peritoneal dialysis is they have a tube in there. We'll talk about it next week, but that tube is going into the peritoneal cavity, so the abdominal cavity, and it's still dialyzing the kidneys. It's not working on the liver, it's dialyzing the kidneys. But anybody who has a tube into their peritoneal space, they're going to be at risk for peritonitis, because remember that the peritoneum is the lining on the inside of the abdominal wall. So if you look at your stomach, you got skin on this side, on the outside, on the underside, before you got to the organs, is the peritoneum. It's a lining. It's just a protective layer under the abdominal wall. So if you have a tube like peritoneal dialysis tube, it can cause peritonitis. So I'll go through these other organs in a second. You know, you have the liver. This is the spleen here. The spleen collects a lot of blood. It stores blood. It stores white blood cells. So again, that is why if the spleen were to rupture, it could cause internal bleeding and death. But you could remove the spleen if necessary. Also, if you had really bad hepatomegaly, a lot of enlargement of the liver, just think that's going to put pressure on the spleen, cause issues with the spleen. So I'm just trying to show you everything is connected. And if you know how the body works, then it will make more sense. It'll help you pick the right answers on your exams. It will help you kind of in your mind envision what's going on. So going back, look at where the gallbladder's at, right? The gallbladder is like a little change purse for the liver, okay? It's like the liver's purse, okay? The liver dumps the bile into the gallbladder in this little bag there, and it just stays there. And then as bile is needed, the gallbladder contracts and pushes more bile down into the duodenum, right? So if you have a collection of stones in here, it's going to cause extreme pain when your gallbladder contracts, right? Because I just got a bunch of rocks built up in there. Or if you get an obstruction here somewhere, it's going to cause issues with bile backing up. So now this is like a balloon and it's getting inflated. So it's going to be swollen and become inflamed. So that's why you have the symptoms. The suffix lithiasis means stones. So nephrolithiasis means stones in the kidneys. Cholelithiasis means, oh, I spelled that wrong, but cholelithiasis means stones in the gallbladder, okay? Chole refers to gallbladder. Cholecystectomy is removal of the gallbladder. Ectomy means removal. Ooh, damn, how'd I get there? So anyway, what's going on here? All right, very sensitive mouse. Okay. Sheesh. I don't know what's going on. Anyway, high risk, females, gonna be middle-aged adults, high fat diet. The purpose of bile, what bile does mostly is emulsifies or melts down fats. So when you eat fatty foods or you have high cholesterol, it's going to cause issues because you need more bile, right? And that's going to lead, you're overworking the gallbladder or you're overworking the liver also, because high cholesterol can lead to fatty liver disease. You're overworking them. You need more bile to break down the fats. So that's going to put you at risk. And hence why after you even have your gallbladder removed or when you have gallstones, the instruction is a low fat diet. You don't want the gallbladder to have to work hard eating a whole lot of fat. So that's that. And then these are some other risk factors and they're in your book, right? So cholecystitis manifestations, because of where the gallbladder is, the pain's going to be in the right upper quadrant. Pain is going to be intense when it occurs, because think about it, you got that little small gallbladder, it's filled with rocks. So when that pain is occurring, you know, it's contracting around these rocks, causing sharp pains, okay? The pain is going to be colicky. It's going to be coming and going, sharp, dull, colicky, okay? And they may have dyspepsia, indigestion, burning, whatever. But the main thing is right upper quadrant, colicky-like pain. It's going to occur usually after eating, especially eating foods high in fat. Anything that you eat some food with a lot of fat, and now that gallbladder has to work to dump bile, it's going to cause pain, right? You don't really need to know these particular signs necessarily as a nurse, but you do need to know rebound tenderness and what it is. So pushing on the abdomen and then removing that pressure is going to cause pain. rather than, it's not pushing on the abdomen that caused the pain. It's actually when you pull your arm away and remove that pressure. So if you all just push down on your stomach now and then pull back, that is rebound. You would have pain when you pulled back. That's rebound tenderness, okay? It can be called Bloomberg sign. Rebound tenderness is common with cholecystitis. It's also a finding in peritonitis, okay? Murphy's sign, again, you don't need to know these because these are things for the examiner, the doctor, the nurse practitioner, whatever, but just giving you an idea of things that may come up with cholecystitis. Jaundice, again, bile. When we talk about the liver, I'll tell you about jaundice, but bile is yellow. You've seen it. I'm sure you've all seen, I mean, has anybody ever had a hangover or something where you threw up so much, you throw up bile, okay? It's yellowish, orangish in color, okay? It gets that yellow color from bilirubin from the liver. Bilirubin, when it is, now you have this obstruction and bilirubin's backed up in the liver can't handle the bilirubin, and now it's in your blood system. That's how you end up with jaundice, and we'll talk about that in a second, okay? Icterus is just yellow in the whites of the eyes, okay? They may have clay colored stools because of the lack of bile and the fact that their food's not being broken down. They may have fat in their stool because the fat is not being broken down. Steatorrhea is fatty stools. You would also see that with Crohn's disease because, again, remember, Crohn's is affecting the small intestine. That is where the bile is being dumped and doing its work. Steatorrhea or fatty stools is going to look like grease. You're going to look in the toilet, you're going to see probably, feces, but it's going to look like grease floating on top of the water, oil. You're going to actually see that. That is a sign that there is an issue with fat digestion. So either there's an issue in the small bowel and the bile is not able to do its job in the small bowel, or there's an issue with getting the bile to the small bowel, because bile is what emulsifies fats. So that's when you'll see fat in the stool. Bilirubin in the urine is going to look dark anytime you have bilirubin, because now the body, bilirubin is a waste product. It is usually let out through your GI tract in your stool, right? If the bowels aren't moving and they're not doing what they're supposed to, or the gallbladder is not able to, and the bile ducts are obstructed and there's no bile, it's backing up backwards into the liver, and now it's being released into circulation. So your body has to compensate. So what it will start to do is it will pee out the bilirubin, and that's called urobilinogen. Okay, you'll see urobilinogen on a urinalysis. Anybody who's a CNA or works in a doctor's office, look at a UA when you print the results. Urobilinogen is on there. And if a patient has a lot of urobilinogen in the urine, it's going to be dark, tea-colored, foamy urine, okay? Pruritus, itching, that's going to come because now you got all these bile salts built up under the skin. And in older adults, a lot of times their symptoms for everything is subtle. So you always want to look at delirium and confusion for older adults. White blood cells may be elevated again. LFTs, because we'll talk about those in a second. That means liver function tests. I'll tell you about that when we get to liver. But again, because of the way things are connected, if stuff is going backwards, it's going to cause inflammation of the liver. Amylase has to do with the pancreas. We'll talk about that in a second. If it's really bad and now stuff's backing up in, see, all these things are connected. So an issue with one could lead to an issue with the other, the bile, the biliary organs, okay? It's usually diagnosed on ultrasound. Here's some other tests you could do, but ultrasound is usually how it's diagnosed. As a nurse, what do I need to consider? I need to know a low-fat diet is what I'm going to teach this patient about. Administering analgesics. With all these disorders, liver, pancreatic, and gallbladder, the pain can be so severe, they need opiates. Depend on the issue, maybe they'll get IV Toradol. But again, you're not going to give them oral. You want to give them IV or injectable pain meds to avoid, further upsetting the GI tract. But Toradol, again, it's an NSAID, so it's going to put you at a risk for GI bleed. So you need to be mindful of that. If the patient's already at risk for GI bleed with certain conditions or any type of bleeding, you may not give Toradol, okay? Incision care, again, the same for anybody who's having abdominal surgery. The patient who has an open cholecystectomy may even have a drainage tube put in. So you need to know about tube care. All this is in your books, okay? Your ATI and your Lippincott books. Potential complications, again, electrolyte imbalance with any of these GI. Cholangitis will be inflammation of the actual bile duct, or choledocholithiasis. That means the stones have come outside of the the gallbladder, and now they are in the common duct, bile duct. They're in the duct. So, and that will cause, I meant to put bile duct, but I don't know. But then that will cause obstruction, which that's how stuff backs up to the liver and the pancreas. And then less likely you could essentially have peritonitis. Treatment is usually a surgery. Usually they remove it. Unless they're trying to avoid surgery, they may do lithotripsy. Remember, lithiasis is stones. Lithotripsy is used in gallbladder and in the kidneys to bust up stones. It's a laser to basically break up those stones. Pancreas. So here's the pancreas again. Remember, the pancreas creates those digestive enzymes and then it dumps them into the duodenum here. It also, when we talk about later endocrine function and diabetes, the pancreas is the organ responsible for making insulin. So issues with the pancreas can lead to diabetes. People with type 1 diabetes, it is completely due to a pancreatic failure, whether they're born with it or whether it develops from chronic pancreatitis. Failure of the pancreas to produce insulin is type 1 diabetes. You don't really need to know the ins and outs of diabetes right now, but you need to know how the pancreas functions and what failure of pancreatic function can lead to. So inflammation of the pancreas can be acute or it can be chronic. Remember, acute means sudden onset. It lasts for a short period of time and the damage is reversible if it's acute, versus chronic usually is happening more slowly. The symptoms are more subtle and the damage is irreversible. Okay. So here's the different risk factors. Alcohol, definitely. Alcohol is a cause of acute and chronic, okay? And then the other things that could lead to issues are gallstones, and again, a high-fat diet and having excessively high lipids in your blood, especially triglycerides. A person with severe elevated cholesterols, like you'll see someone, a triglyceride is normally less than 150. If their triglyceride is 1,000, the main concern is you're going to lead to pancreatic failure, which could kill somebody, okay? Or pancreatic necrosis, which could lead to a GI bleed and death. And then infection, and much less common could be certain medication. So with the acute, it could be mild or it can be life-threatening, okay? Because of the shape of the pancreas, right? You have the head. This is called the pancreatic head, and this is called the tail. Because this is so small and everything, this part tends to, when there's severe inflammation, it can become necrotic and die. and start to hemorrhage, okay? Because of that, you may witness these signs. The bleeding in the left or in the flank area, blood collection in the flank area would look like bruising, excuse me, bruising on the skin. But what's really going on is that's bleeding going on up under there, or bruising around the belly button. This is Cullen's sign. This is Gray Turner's sign. I will be honest, I have seen a lot of people with acute pancreatitis. This is going to be late. I really haven't seen anybody with these signs as related to pancreatitis. Now, you do see other, like you will see Cullen's sign in any intra-abdominal bleeding though. Usually it's going to be epigastric, severe pain, and it's going to radiate to the left upper quadrant. Their pain is going to be severe, just like the gallbladder. Their pain, anybody with issues of the pancreas, because of all those enzymes, they make enzymes to break down protein, fat, everything you eat. So because of all that work that the pancreas does, when a person eats, that is when their pain is going to be the worst. People with acute or chronic pancreatitis don't want to eat. They have anorexia. They do not want to eat, and their pain becomes severe whenever they put food in their mouth. Whenever it gets down to the stomach and the pancreas has to start producing enzymes, that is causing severe pain. This is another one. The fetal position or any position that draws the knees up to the chest is going to relieve the pain. They're going to have nausea. They're going to have vomiting. And guarding, abdominal guarding. That means I'm holding it. I'm protecting it. I'm holding my stomach. It hurts so bad. Don't touch it. Don't look at it. The labs you need to know for pancreatitis are these two highlighted in yellow, amylase and lipase. Those are pancreatic enzymes. Amylase is going to become elevated right away. It will be elevated within 24 hours and remain elevated for a few days. Versus lipase is going to come later and it's going to be elevated for several weeks likely. And a patient with chronic pancreatitis, their lipase may be chronically elevated. White blood cells, and they may be elevated, they may not be. Bleeding, if they have any hemorrhage going on, they may the H&H may be low. Platelets again may be decreased, but these aren't so big as amylase and lipase. You need to know those. And then fluid electrolytes, you can do these labs on everybody. CAT scan or ultrasound. The ultrasound would rule out gallstones because if there is an obstruction in one of those bile ducts, that could lead to pancreatitis. The treatment for acute pancreatitis is going to be MPO. I forgot to put on this list too. They're going to be MPO and they're going to get IV fluids. No food, and giving them IV fluids to keep them hydrated. They need pancreatic rest. If it's really bad, maybe they even need an NG tube to keep the stomach empty, okay, for pancreatic rest, okay? You may give them nausea, pain meds. The one thing I forgot to put on this list that you need to know is proton pump inhibitors. Patients with acute pancreatitis are likely going to get a PPI. So you need to know about those meds too. Now, chronic pancreatitis. Same risk factors, okay? Chronic alcohol abuse, obstruction, if it tends to be chronic, but also cystic fibrosis. We'll talk about that when we get to lungs. But cystic fibrosis causes this really severe overproduction of mucus, and it fills up the lungs and it coats the digestive organs. So it can lead to chronic pancreatitis. Treatment, the symptoms really you're going to see when you see someone in the hospital, they're there because they're having an acute flare up. So even though they have chronic pancreatitis, it's going to be an acute flare up. So symptoms are going to be the same. A lot of the teaching and treatment is going to be the same. But now with the chronic pancreatitis, they're also going to be at risk for diabetes and malabsorption. So on top of the other treatments, pancreolipase, this is what you call exogenous, meaning it's from outside the body, because you'll see that, oh, this person is taking exogenous insulin. That means they are taking medication. It's not about the endogenous inside the body. So exogenous pancreatic enzymes, the medication is called pancreolipase. It is to be taken with food, not before food, not after food, not an empty stomach. You take it with the food. You put it in the stomach as you're eating because it has those enzymes to start breaking down the food that your, chronically inflamed pancreas is no longer able to produce. In acute pancreatitis, everything is reversible. They don't need pancreolipase. Chronic, it becomes irreversible damage, and now you need enzymes supplemented. Surgery they may get is the Whipple. Whipple procedure is a crazy surgery. They remove all the organs out of the abdominal cavity and resect the pancreas. But you don't need to know that. It's just a surgery that could be done. You don't need to know the ins and outs because you're not a surgeon. Complications, again, I already told you, bleeding, hemorrhage, DIC, you'll learn about next semester, but that comes from a systemic inflammatory response. And that hemorrhage comes from the death of that pancreatic tail. A systemic inflammatory response, just like with sepsis, I told you that can occur. Now, anytime anybody has pain in the abdomen, or if they just had abdominal surgery, you want to worry about the risk for pneumonia or pleural effusion, which is a fluid collection around the lung. That occurs because the people aren't taking big, deep breaths. Why? Because it hurts my stomach. Because the pancreas is in the left upper quadrant, they're likely to have a pneumonia on the left side if they are not coughing and deep breathing every hour. And then we'll talk about third spacing in a second. Last organ, liver. Again, like I said, the liver, it does so much. Look at this list of things the liver does. The main thing with the liver is it's got these two blood supplies, right? Last week I told you the portal vein carries the portal venous system. When food is passed through the intestines, it passed through the stomach, and nutrients are being absorbed and waste is being excreted. Some of that blood from the intestine, not some of it, all of it, the blood from the intestinal tract travels up the portal venous system. Okay, it's bringing the blood to the liver. Why? Because the liver is that main filter. So the intestines did its part in filtering. Now the liver is going to maybe hold on to store some extra vitamins that we may not need right this second. It's going to filter out the waste, especially waste with like medications and drugs. The liver plays a role in glucose management. The liver produces glucose, okay? And it stores glycogen, which is a breakdown product of glucose. When the insulin is breaking down the glucose, it's broken down into glycogen and some other stuff, and then it's going to go and be stored in the liver. Because when your blood sugar drops, per se, the liver, or when you need more energy, the liver is smart enough to say, all right, let me piece that glycogen back together and make some glucose molecules. Okay, so if someone has a diseased liver, their blood sugar may be low. Okay, and then it metabolizes fats and cholesterols. Hence why if someone has chronic hyperlipidemia, it can start to cause damage to the liver. You can have cirrhosis from fatty liver disease. So the portal vein, you're gonna want to know about that, because if you understand that, you'll understand all the complications of liver disease. All right, hepatitis. The term hepatitis just means this: itis, inflammation of hepato, the liver. Inflammation of the liver cells. Hepato, sites are cells. Hepato, liver. Inflammation of the liver cells. Hepatitis virus is a virus, okay? But hepatitis, anything with itis, it literally technically just means inflammation. The most common cause of hepatitis is viral hepatitis, but you could also have acute hepatitis from alcohol intoxication, binge drinking, um, Tylenol overdose. That is acute hepatitis, which can lead to acute liver failure, which will kill you. So these are just the different, causes. Sometimes hepatitis can be symptomatic right away, but if you have like chronic, say Hep C, chronic Hep C, the symptoms, you may go asymptomatic for 20 years and not even know you have chronic Hep C. And it's going to lead to enlargement of the liver. Here's the different types of Hep virus, okay? You need to know these routes of transmission. Hep B and C are mostly transmitted through blood. I mean, not mostly, they're transmitted through blood. Could possibly be transmitted through sexual intercourse, but mostly are transmitted through blood, okay? But I did put sexual contact down here. That is a risk, but it's more blood, injecting, that kind of stuff. So because of that, the people who are going to be at risk are going to be the ones who use IV drugs. IV drugs is going to be the people you most commonly see hepatitis with. Alcoholics also a lot of times end up with Hep C. The thing about Hep B is it doesn't occur as commonly in the United States. Why? Because we have a Hep B vaccine. We give it to babies before they even leave the hospital. Hep B vaccines have prevented the spread of Hep B in the United States compared to other countries. To get Hep D, you must have Hep B. So because of that, Hep D is even less likely to be found in the United States. Now, I'm not saying it can't happen, but in order to get Hep D, you have to have Hep B first, okay? Now Hep A and Hep E are going to travel through the fecal oral route. Does that mean the person ate poop? No. But what it means is you got somebody going to the bathroom, not performing proper hand hygiene, and lo and behold, now everybody's got diarrhea and abdominal pain because you gave them Hep A or Hep E. Hep E is more commonly found in contaminated water, and that really is only found in underdeveloped countries. You don't really see that in the United States. But Hep A made a comeback lately in the last 10 years. Hep A used to be mostly just in underdeveloped countries, but I don't know what's going on with us where we got problems with hand hygiene in this country, because now we got Hep A everywhere. Not everyone gets a Hep A vaccine like everyone should be getting a Hep B vaccine. Hep A is reserved for those with weakened immune system. So you need to know the routes of transmission, and you need to know teaching based on the routes of transmission, right? So with that, manifestations, just like any other liver issue, is going to cause bilirubin to build up. So they can end up with jaundice. That's from the bilirubin. And here's that tea-colored urine I told you about, tea-colored foamy urine. When you have that urobilinogen or bilinuria, whatever, bilirubin in the urine, okay? When you have that, it's going to be dark color. Now, on a dark-skinned person, it's going to be difficult to assess for jaundice, so you're going to have to look for that icterus, the yellowing of the sclera of the eyes, okay? And then here's some other symptoms. Obviously, disease prevention, like I said, if it's fecal oral route, then teach people how to wash your hands, okay? Hand hygiene. Don't be changing diapers while you're eating lunch. Wash your hands after you change a diaper. Wash your hands after you use the bathroom. Wash your hands, period. When you're traveling out of the country, if you're going to Santo Domingo, you're going to Haiti, you're going to visit a lot of these places, you might want to be mindful and drink bottled water just to be on the safe side, okay? Now, sometimes, like, say you're born and raised in Haiti or somewhere. I'm just picking a country. I'm not trying to say Haiti has issues, but I'm just saying if you're in an underdeveloped country and you live there your whole entire life, now a native person from that country who still lives there now, not like, oh, your mom was born in Haiti and you're Haitian. I'm talking about Haitians living in Haiti, for example. Their intestines and normal flora may have adjusted more than you coming as a visitor. So just because you see people living in this country drinking tap water and doing just fine doesn't mean you, the American with the naive intestine, is going to end up just fine. So when you're traveling to an underdeveloped country, they always tell you drink bottled water. You know, watch how they're use plastic utensils rather than washing it in the tap water. Okay. And then of course immunizations. Now, what's the other way a person could get Hep B? How about if the mom has Hep B and passes it to the baby? If the mom is pregnant, has Hep B, and delivers a baby, the risk for Hep B is very high. So you are going to give them a vaccine, but first you're going to give them the immunoglobulin. Remember that from immunity, and you see how things were building up on information each week. Information that you learned in week 1 is still going to be important in week 16. Okay. So uh, with the immunizations, Hep B, you're going to administer the immunization before the child leaves the hospital, but you're first going to administer immunoglobulins to help boost their, we don't got time to wait for their body to build antibodies, right? Immunoglobulin is what's called, not natural, artificial, what was it? Artificial passive immunity, right? Artificial. It's artificial. It's immunoglobulin outside of the body. Those are antibodies that were created outside of the body, and they're being passed on passively. It requires no action. Where an immunization is going to require action, right? So you're not going to give them a Hep B vaccine and expect them to all of a sudden fight off Hep B. That takes time. It takes a series of 3 injections, right, to build up those antibodies. And this little newborn baby ain't got time for that. We got to give them the immunoglobulins first, and then about 12 hours later, you can give them the vaccine. Now moving right along to labs. LFTs are highlighted in yellow, right? You got the ALT and AST. ALT and AST are the main 2 you're going to look at, especially in early liver disease. Alk phos is going to be elevated the more damage that's caused. So if it's just an acute hepatitis, a person may not have an elevated alk phos, but if it is cirrhosis of the liver, their alk phos is probably going to be elevated. Everything's elevated, okay? But these are LFTs. These are the liver function tests that you're going to look at: ALT, AST, alk phos, and bilirubin. Bilirubin. What is bilirubin? Well, remember, your cells don't live forever, right? Cells don't live forever. And because cells don't live forever, eventually red blood cells die. And as red blood cells die or they're breaking down, a byproduct of that is bilirubin. Just like glycogen is a byproduct of glucose, bilirubin is a byproduct of hemolysis, death of the red blood cell. So bilirubin, if something's going on in the body, we'll talk about it later. If something's going on in the body causing red blood cells to die rapidly, the bilirubin's going to be up. When you get later on in your program, either later in this semester or next semester, you talk about blood transfusion reactions, and there's 4 different types. Hemolytic blood transfusion reaction is you're having an allergic reaction and it's causing those blood cells to die, and it's going to elevate the bilirubin as well. When the bilirubin becomes really high, remember normal is only to 1.0. So when it becomes greater than 5, that patient's going to be jaundiced, okay? Or they're going to have yellowing of the eyes. When we talk about labs for hepatitis, okay, Hep A, you should have never in your life came in contact with Hep A. You're not supposed to come in contact with it unless you received an immunization, which is rare. But usually, if you never received an immunization, you shouldn't have come into contact with it. So when we draw your blood, your body shouldn't have any antibodies produced. It doesn't know Hep A. It's never seen Hep A. So when you have positive antibodies, that usually means a patient has Hep A, unless if they had a vaccine, then you probably need to look for other things. Hep B, so like the surface antigen would detect that the infection is around, right? But if the infection is around, but you also, I want you to look at this bottom line. This was supposed to be antibodies, not antigen. It could be antigen, like the antigen could be positive, but if they're antibodies right here, well, that's for Hep C, but if the antibodies are positive, that means that person got an immunization. They don't have Hep B, they are immune to Hep B. Remember, antigen versus antibody. Even if you didn't know these tests, if you knew what those two words meant, 9 times out of 10, you could figure out the answers to questions. Okay? Hep C, again, you should have never come in contact with Hep C. So when you have an antibody present, it means your body came in contact with Hep C. The cool thing is your immune system is so strong that sometimes for some people, for whatever reason, they come in contact with Hep C, but they never get sick. They never get the disease. Their immune system was able to keep that virus in check. So antibodies alone is not going to tell me that a person has Hep C. It is going to tell me that they came in contact with it. What I need to do is look at the RNA. Remember with HIV, RNA is the viral load, okay? The viral load, it's what you look at to determine if treatment is working. RNA, DNA, those are the viral loads, okay? So if this patient has the presence of antibodies, okay, I know, okay, they're probably an IV drug user. They probably have been exposed to Hep C, but it's not going to make them sick because their RNA is negative. They don't need treatment. Biopsy is always going to be most definitive for any liver disease. Biopsy, you're going to stick a needle in, you're going to take a piece of the liver and you're going to look at it under a microscope. So you need to know the care for a patient with a biopsy. You don't need to know how to do a biopsy. You're not doing the biopsy. You need to know how to assist the doctor and what to look out for and what to educate the patient about. So they need to be NPO anytime you're doing a procedure on the abdomen. They're going to need pressure. Think of all that blood flowing through the liver. Once you've cut a piece out, there's going to be a lot of bleeding after that. They need a pressure. Either you apply pressure or you apply a pressure dressing, a dressing that's going to apply pressure. And then you're going to monitor the site for a hematoma, a collection of blood underneath the skin, which means that patient may be having intra-abdominal bleeding. Other complications, you don't need to know what a pneumothorax is for this exam, but I'll tell you what it is. If they're sticking that needle in and they accidentally poke your lung instead, air from your lung is going to escape and cause, the lungs are in a sac and it'll cause pressure on the lungs. We'll learn about that with lungs and hematoma because all the blood that flows through the liver. You need to know the diet for liver, high carb. This is moderate fat and moderate protein. However, if they really have liver failure, low fat, low protein, okay? High carb, high calorie, low fat, low protein. For people with hepatitis, remember it causes flu-like symptoms. So they're gonna be fatigued. They may need plenty of rest. Okay. You need to talk to your doctor. You need to instruct, first of all, alcohol. Anytime something wrong with the liver or the pancreas, you need to avoid alcohol at all costs. And you need to talk to your doctor because you're not a pharmacist. You don't know what meds are filtered through the liver. So you need to teach the patient anything you take over the counter, you need to talk to your doctor about it first because you don't want to cause more inflammation in the liver. Cirrhosis causes that inflammation eventually causes scar tissue. So the healthy, like the liver can regenerate its own cells if you treat it right. If you treat it right with a little TLC and avoid alcohol, it can regenerate itself. However, if all the tissues of the liver have turned into scar tissue, it's not going to be able to regenerate and it's losing its function as a liver. So that could be most likely alcoholism, but there are other things. If you've had chronic hep C or chronic hep B or hep D, which we rarely see, but any chronic hepatitis can lead to cirrhosis. Autoimmune. If you have autoimmune hepatitis, how are they going to treat autoimmune hepatitis?
Steroids.
Yes, thank you. I know y'all are falling asleep, but yes, okay. If it's autoimmune, it's steroids and immune suppression. No matter what part of the body, if it's dealing with the autoimmune system or not disorder, that's the same treatment, okay? Here are the clinical manifestations. You could read through those. I'm trying to get y'all to lunch, so I'm going to show you. You know, you can read through these signs and symptoms, but I really want to explain to you why. If you know how the liver works, then you'll understand why these things are happening and what they look like. This is ascites. These are what they call spider veins, spider nevi, whatever. So what's happening, remember, this is the portal venous system. It's bringing all the blood from the digestive tract and it's filtering it through the liver. If this liver is all scarred up, like keloids, remember, like I said, if it's all scarred up, it's not functioning, it's just a bunch of dead scar tissue, then guess what's going to happen? This blood flow is going to reverse. It's going to go backwards. It's going to go backwards, and the intestines are not going to be able to handle all that blood coming backwards. So what's going to happen? Your body is such a phenomenal thing. It will create new blood vessels. It will create new blood vessels. And remember, everything's going backwards. So it's coming through the portal vein, going to the large intestine, going back to the small intestine, going back to the stomach, and eventually what? The esophagus. So as that blood backs up, you have collateral circulation, which means they made a new path. So say in heart disease, this happens. Say I have heart disease and I got all this plaque built up right here where my arrow is pointing. The body, the heart, the vascular system is so amazing that it may produce a new vein to just go around it. I'm going to bypass that blockage. That's called collateral circulation. I'm making a new path, all right? And what happens in the esophagus, everybody know what varicose veins are? You've seen those ugly bulging veins on people's legs? It happens due to high pressure, and you get these super dilated veins. That's what happens in esophageal varices. The blood has backed all the way up, and now you have these engorged, swollen blood vessels full of blood. So that's why a person could die quickly with the esophageal varices rupture, okay? And then ascites, right? So you have this pressure, high pressure built up, right? So now fluid's even going to leak into the abdominal cavity. The liver breaks down proteins. It provides proteins for the body and for the vascular system. Albumin. These are things you need to know when you take your test. Albumin is what makes it's a plasma protein, and it makes the blood vessel wall strong. it keeps the blood vessel wall strong to keep all the fluid inside the blood vessel, inside the vascular bed. A liver failure is going to lead to low protein and low albumin. As your albumin depletes, that sliding glass door opens and the blood vessel wall becomes like a screen door, and now water, fluid is just flowing out. So because of the high pressure in the portal venous system, and then the low pressure keeping by the albumin provides pressure in here to keep the fluid in. Because of the low albumin and the high pressure of the portal vein system, you end up with this ascites. This is a sign of, and these are late signs of liver failure. So that's why you're not going to see this with acute hepatitis. But if you see ascites, that person is at the end stages of liver failure. Esophageal varices, end stages of liver failure. Okay. And then protein, when it's broken down, one of the byproducts, the waste product of breaking down proteins is ammonia. Everybody knows what ammonia smells like. You wash your kitchen floors with it. Imagine that building up in your body. It's going to be devastating. It's going to cause what's called hepatic encephalopathy, confusion, irritation, and eventually lead to coma. Okay? So diagnosis is going to be looking at those labs. Like I said, ammonia, albumin's going to be low, LFTs. If they have jaundice, you can expect they have a high bilirubin. Same scans. Medications. You need to know, okay, propranolol, it's a beta blocker. What's it going to do? It's going to lower pressure. This is not cardiac specific, propranolol, so it will lower pressure in the portal vein, okay, the portal venous system. So hopefully preventing esophageal varices from rupturing, right? Diuretics will help you just pee out that fluid. Lactulose, you need to know about lactulose and why you're giving it. Lactulose is a laxative, but in the case of cirrhosis, it binds to ammonia and helps you excrete it in the stool, right? So that's why you give lactulose. Same thing with non-absorbable antibiotics. Those will do the same thing, bind to the ammonia and cause you to poop it out, basically. And then on the next screen, I tell you about these other procedures. So with the esophageal varices, again, I'm gonna let this video play because it has no sound. I'm almost done, I'm sorry. And then we'll go on a long lunch. Varicose veins have occurred, and varicose veins have occurred. Maybe she's not playing, but anyway, you need to watch these videos because this is an excellent video of the doctor is going in, you see all that bleeding in there, and you actually get to see her wrap a rubber band around and perform the ligation, esophageal banding or ligation. Okay, this is an excellent video of that. So because they're like varicose veins, and because this mucous membrane and the delicate, state that the esophagus is in, and then add to that, if the person is already drinking alcohol or something that's also going to irritate the esophagus, it's very easy for these to rupture and kill. A person could die in a matter of minutes from rupture of esophageal varices. Can you survive it? Absolutely. My uncle was an alcoholic. He had them ruptured twice, okay? But you need to know most people don't survive. You need to know that they can die from this, and this is an emergency. So in the emergent state, they may insert a Blakeman oral gastric tube or a nasogastric tube. You need to know about that tube. That tube is inserted just like this tube was inserted. This is the camera. But this tube, the balloon tamponade, what happens is the tube is inserted, right? But on the outside of the tube is actually a balloon, okay? And you stick the tube down, and then from outside the body, you inflate air, and the outside of this is going to inflate and put pressure on that bleeding site. Of course, With that, you need to monitor airway. You got to monitor airway. You need to, you know, make sure it's not causing any problems. And again, this is only temporary. This is a temporary use to stop that hemorrhage so the person doesn't die. They're going to be in ICU. And they're going to go to surgery or endoscopy to get a procedure to really stop the bleeding. Okay, so the concern with this is going to be, you're going to monitor a CBC, you're going to monitor blood count, you're going to look for signs of shock. And then with ascites, it's paracentesis. Here's another video I want y'all to watch. And it shows you the procedure of paracentesis. Paracentesis is similar to being pregnant. It's causing all that pressure in your belly. People are going to be short of breath. They're going to really, what's called early satiety, means they get full really fast. Like when someone says they have an insatiable appetite, it means they're like a bottomless pit. They can't stop eating. Early satiety means I'm about to eat 3 kernels of corn and my stomach is full because it's damn near collapsed because all this fluid pushed up into my belly. You're going to teach them about diuretics, low sodium, because water always follows salt. So low sodium diet to help prevent worsening of the ascites. And you're going to monitor abdominal girth. Last thing, and then I'm going to let you guys go to lunch because it's on like a few more slides after this, and I'll do them when we come back. But cirrhosis education, you need to know the diet. Need to know the diet. You need to know that these people are usually very malnourished with cirrhosis. And not only because of the disease itself, but also look at the diet they have to be on. Low protein. It's really like moderate and low fat. So how the heck am I going to nourish someone who also needs a low protein diet? So malnutrition is huge with liver disease. Thiamine, vitamin B1 deficiency. Thiamine has alcoholics. There is such thing as a special dementia. We'll learn about it later. That comes with alcoholism. It is due to vitamin B1 deficiency. It causes cognitive disorder. And then you need to educate them because patients are not going to who wants to go to the bathroom all day, every day? Anybody who works in a nursing home is familiar with lactulose. It's like a liquidy, it's just a nasty laxative no one wants to take. They're usually taking it like 4 times a day. So they typically refuse. But you need to understand that the lactulose is preventing them from going into a coma caused by hepatic encephalopathy. So I'll do the last, what is it? 1, 2, 3, 4. Yeah, I'll do the last slides. I think it's like 5 slides when we come back from lunch. Cause I know this is a lot. Any problems, questions, concerns, anything? Do you feel overwhelmed? Do you feel like you're learning? Yeah, 3.5 to 5 for albumin. Yeah. Anybody else have any question, concerns? Sorry, I just saw that now. No? You ready to eat or at least get away from me? Okay, cool. Great. The feeling is mutual. It's a lot better, but with the reading, it comes together better. Yes, exactly. That's why you're overwhelmed. Oh, Kanisha, look, I'm telling you, we're going to do practice questions together after this because I want you guys to be able to tie this all together. We'll look at a case study so you can tie all the information together. So don't worry. Don't worry. My goal, I'm your coach, okay? I am not trying to coach no losing team, okay? No. I'm trying to be like the 86 Bears, okay? Or 85. I don't know. I'm from Chicago. I know they won either the year I was born or right before I was born. But I'm trying to produce a winning team of nurses, okay? I don't want anyone to fail. If anybody has problems, I am thinking about starting next week with my office hours times. I'm just going to have weekly tutoring. So if people want to get an extra Zoom in or an extra, extra review in, I'm going to offer weekly tutoring like I'm doing for Nursing 3. But I'm telling you, when we go through this stuff together, it'll get easier and we'll keep building on the information. So have a great break. We'll get back together around 1:30. Is that good? That's an hour and 10 minutes. You should be able to take a nap if you need to. All right, Carly, tell your mom she's so cool. Is she a manager or a nurse practitioner? What does that lady do? I know she's not just a regular floor nurse.
Okay, so she was a floor nurse when she was younger and she kind of did like everything, but right now she specializes in geriatrics and she does home health and she like is precepting nursing students at like a psych unit.
Oh, okay.
So she's kind of like running a dementia psych unit and she's kind of like her own boss because her boss just kind of like lets her do what she wants, but she's like, you
So
know.
you know what that's called? You know what that's called?
The what?
You know what that's called? She has autonomy. Autonomy. She
Yes.
has all the control.
Yeah.
So yeah, so that's good. That's what I did too. That's what I recommend, honestly. When you get out there, you get a little med surge experience because that will best prepare you because you get exposed to so much. But then afterwards, float all around. The opportunities are endless. Float all around. The more exposure you get, the more you learn. That's why I say maybe some teachers aren't explaining things as good because they have never seen this stuff in real life. Me, I worked on every single floor the hospital had as a young person in my early 20s. I floated from everywhere. And then I am, like your mom specialized in geriatric, I'm specialized in ER. So again, I worked in a poor neighborhood. A lot of people use the ER just for primary care. So I saw everything from trauma all the way to ear infections in the ER. So the more you float around, the more exposure you get, the easier it is to understand. Yeah, I would find it very difficult to teach somebody anything I've never actually seen in real life. So
Yeah.
yeah. All right. So anyway, break time. See you guys at 1:30. Oh, Lord.
Professor Cook, could you go back to that screen?
Which one? This one?
The one with the questions.
What questions? You can see everything? Oh, hell no. How can you see that? I'm gonna change everything now.
Don't do that.
No, now I have to. Shit. Now I gotta rewrite the whole test. How can it show you that?
No, honestly, it was just like a little glimpse. I just saw something about a rationale. That was it.
No, but I've been flipping back and forth, so now I'm gonna change all of it. All right. Shit.
I can have a water
Oh, this mic was on the whole time.
Okay, my bad. I'm back now. Hold on one. Oh, wait, what's going on? Oh shoot. Oh, I just emailed the study guide to you all. I had a delay because Zoom wanted to change on me, and before I could just select one program to share at a time, but I guess now it's sharing my whole screen. So I was sharing like the last 10 questions on the exam. So I had to go back and redo that. So thank you, Whitney, for pointing it out. So I had to go back and do that and then redo the study guide. But I did just email. No, it's okay. I emailed it. It's better this way. Challenge yourself. Don't cheat because it's not going to help you when it comes to the proctor or NCLEX. Definitely not NCLEX. You can't even barely use the bathroom at NCLEX without getting a pat down. So yeah. So give me 1 second. I gotta go grab my coffee. Hold up. If anybody's in the waiting room, tell them I'm coming right back. But I think I got everyone in. Mm. Okay, my bad, my bad. Okay, real quick, Soraya, your email address, it doesn't
Yeah.
work. The Sweet Success 21. Did you just get the study guide?
Yes, ma'am.
Oh, you did? See this? That's why I hate Outlook. It's so janky.
I
It
got it. I
it's
didn't get the
an
last email.
error message. Okay, but you just got it right now. Okay.
Yes, ma'am. Mhm.
It tries to tell me I can't. That's why some people weren't getting emails. It's because the Outlook doesn't always want to send emails to outside email address is outside of Outlook. You know, I think it's something maybe the school has on there. I don't know. But every time I try to send a Yahoo or Gmail, it sends me an error message. But as long as you received it, you received. What about you, Whitney? Because I always get an error on you too. Send it to my email. Okay, Alina, can you type in your regular email right now? In the chat? Okay, let me. And then Whitney, check your email if you're there. Check your email and tell me if you got it. Because I know I always have the same thing. All right. Sorry, hold on. I just want to make sure everybody has everything.
I have mine.
Whitney, that's you? You got
Yes.
it? Okay, good. All right. Now, where the heck is this? What's going on here? Here we go. All right, good. I want to make sure I got everybody's email address up in here. I done sent it to every address I could possibly find for people. Who the heck is that? No, let me go back. It wouldn't copy. Lord. Lord. E. All right. Hopefully y'all ate. Anyone have questions from whatever we were talking about before? There is going to be a lot of questions on hepatitis and cirrhosis. It's going to be questions on everything we talked about in clinical. So yeah. Oh, I wasn't trying to respond. I was trying to forward. Bear with me. Bear with me, people. All right. Trying to forward this email. All right. Hopefully you should have got it now, Alina. So, all right. Let me share my screen. It's just like 3 or 4 more slides, and then we'll do some practice questions, okay? Mm-mm. Be careful sharing my screen, shoot. All right, so you see the screen now, right?
Oui.
Okay, and the test isn't pulled up, right, with all the answers? Lord have mercy.
No. I will.
That was grandma move. What the Lord, oh Lord. She was like, can you go back to that screen? I'm like, what screen? No. You saw that? No. How much did you see? Oh Lord. But I know I didn't look at much. I only looked at the last few answers. So anyway, so we talked about what is bilirubin. Bilirubin is a byproduct. It's released when red blood cells die, hemoglobin die, okay? So the concern for babies, and that bilirubin, I'm sorry, is processed by the liver. So in liver failure, they have a bilirubin buildup because the liver is not processing the bilirubin out of the body, and that bilirubin is excreted from the body in the bile. So remember, the liver makes bile. It is going to dump the excess bilirubin into the bile. The bile is going to dump that into the small intestine in the duodenum, and then eventually it's going to pass on through and you're going to poop it out, right? But with the newborn baby, when we talk about immunity, let's go back to immunity. I think most of you guys have children in here, and if you don't, you're gonna learn today, okay? If you've been pregnant before, they test you during your pregnancy for Rh factor to see is your blood type positive or negative. So my blood type was B negative. So when I was pregnant with my son, I was B negative. They needed to know that because if the baby is positive and you are negative, your body is going to recognize your baby as something foreign, and it's going to create antibodies and try to attack the baby, right, while you're pregnant. So you remember the humoral immune system and how antibodies are created. So when a woman's pregnant, you get checked for Rh. The reason being is that your body can really essentially terminate the pregnancy. Right. Okay. So Amanda, you got the RhoGAM shot. So this is why you get the RhoGAM shot. But when you see a baby with jaundice, you have to start thinking what's going on. Are they killing? Are red blood cells dying as a result of during that pregnancy? The mom's body tried to terminate the pregnancy, basically get rid of this. It's recognized the fetus as an antigen and is creating antibodies and attacking the pregnancy. So when the babies are born with jaundice, because jaundice bilirubin occurs from the death of red blood cells, could be an indication that during that pregnancy that the mom's body was attacking the baby's cells. Do you get it? So that's how those babies end up born with jaundice. So because they're just a little baby, they're jaundiced because they have all this bilirubin built up, and their liver is just a little baby liver. So it's not necessarily mature enough to pass it through. So there's two type of jaundice. The one that happens more gradually could just occur because of the immature liver. But when they're born jaundiced immediately, you have to assume it is probably because of an RH or ABO. Like if the mom's A and they're B, it's got to be an incompatibility, but it's usually RH. The Coombs test is the test for RH factor. Okay, that's what a Coombs test is. It's the test for the antibodies, the mom producing those antibodies, right? The reason it's so important is because bilirubin can cause brain damage in the baby. So that's why we want to treat it. With the babies, yeah, this is that antibody that the mom is making to attack the baby. With the babies, we're going to use phototherapy. They're going to be, Amanda, did any of your kids have jaundice? Did anybody's kids have jaundice? And you had to put them under phototherapy? It's like basically laying under it's like laying in a tanning bed or something. Yep. Okay, so Amanda, her baby had that. So yeah. So with that, just think about if you just were laying a baby in a tanning bed, you need to monitor skin integrity, and also think of the damage that could be done to the corneas and the retinas. So you need to protect and monitor the eyes. But for the most part, the baby needs to stay under that lamp until the jaundice resolves. So because of that, you need to monitor their temperature closely, and you need to monitor them for dehydration. Oh, see, and her babies were premature, so that could have been part of it too. You need to monitor fluid electrolytes, or I'm sorry, not fluid electrolytes. You need to monitor for signs of dehydration. Well, yeah, fluid and electrolytes, sunken fontanelles. That's another sign. But anyway, and encourage mom to hold the baby, or dad, whoever, parents, hold the baby as frequently as they can when there's breaks. And you want to feed them frequently to prevent dehydration, but also to get that I spelled that wrong, bilirubin out, right? The bilirubin is excreted in the stool. So when a newborn baby is born, we give it to the mom. We want to, after we, wrap them up and all that, they feed the baby right away. Anybody who's had a baby, they're in there encouraging you to feed the baby quickly, or they'll feed the baby quickly. Why? Because the more quickly you can get them to pass that stool, they're getting that excess bilirubin out, even if it's physiologic and not pathologic jaundice. So now that's it. That's all you need to know. I just want you to understand, like, now you know what bilirubin is, okay? Now you know when you see someone with yellow skin, yellow eyes, I know they have an excess bilirubin. I don't know why yet, but I know, okay, is there cellular death? Is there red blood cells dying excessively? Or is there issue with their gallbladder, pancreas, or liver? Those are really the things. Why do they have this bilirubin built up? So hopefully you guys understand that. And how do we get rid of the bilirubin? It's going to be excreted in the stool. So peritonitis, I kept mentioning peritonitis this whole time. Peritonitis is a life-threatening inflammation of the peritoneum and lining of the abdominal cavity, okay? So the lining of the abdominal cavity and the lining of all the organs, basically, because you've got infection all up in the abdominal cavity. That could be from a perforated bowel. It could be spontaneous. Some people can have spontaneous peritonitis, it's kind of weird, but it does happen. But if they have peritoneal dialysis, which we'll talk about next week, anything that is increasing the risk for an infection in that area. So that is why we are trying to prevent perforation, not only because we're leaking fluid into a third space, but we're also at high risk for sepsis and death. So classic symptoms, this rigid board-like abdomen, if you see that, that is a classic sign of peritonitis. They also have rebound tenderness. Remember what I said, when you push on the abdomen and withdraw, that rebound tenderness. They're going to have a high fever. They're going to be tachycardic. They may be confused. They're going to quickly, it's going to be quick and sudden signs. See, oh my gosh, 29 hours old. Oh God. Yeah, respiratory. Yeah, you're dying. You're going hypovolemic. You're like fluid is leaking out. You're extreme infection. This is a serious infection. This is sepsis. You're hypovolemic. You're not getting enough blood circulating because of this. You have widespread vasodilation, respiratory distress. Yeah, you're gonna be breathing fast regardless if you have a fever. But if you're septic, and everything is going to be out of whack. If you're septic, what happens? Remember, I told you the blood vessels dilate, they open up everywhere. That bacteria is releasing toxins that is just causing this system-wide inflammatory response. Everything's going to be out of whack. You're going to see no urine output. You're going to see a loss of consciousness. Sepsis kills people. So preventing perforation will prevent this. We don't want peritonitis and we don't want perforation. So your son Jenny, did he get his colostomy reversed or does he still have it? Oh, he got it reversed. Good. Yeah. A lot of times with the kids, they are able to reverse it, but adults too. A lot of people, it just depends. Ooh, 14 years. Good. See, that's scary. Why did he have a rupture? Did he have intussusception or why did he have a perforated bowel? Oh, ooh, vanishing twin syndrome. Oh. So like he ate his twin? Look, I'm not a neonatologist, okay? Oh, God. Okay, that's what I assume. Vanishing twin. Ooh, well, there's a medical wonder there. Okay. Well, thank God he's doing well. He got his colostomy reversed. Okay, peritonitis. So again, yes, you're monitoring. This person is going to go into shock. Okay, you're monitoring their vitals. You want to keep them more upright. You don't want this infectious drainage going up towards the heart. And I mean, let gravity work with you. Also, anybody who has abdominal pain, abdominal surgery, anything, breathing, this sitting upright is going to allow more expansion of the lungs and improve your respiratory status. So semi-Fowlers or Fowlers or semi-Fowlers for peritonitis. NG tube likely, yes, to suction out any infectious stuff in the abdominal cavity, well, in the belly really, and decompress the bowel. And then you're gonna, like I said, monitor for shock. Oh, don't have to worry about hypertonic, hypotonic IV fluids. We'll talk about that next week. But this is a serious condition. It requires urgent attention, emergent attention, not urgent. So likely they're going to need surgery. If it's a perforated bowel, they need emergent surgery or they will die. And now because all these diseases and things we've talked about could lead to surgery, I just want to incorporate perioperative care into this, okay? Because no matter what abdominal surgery, most of them, I mean, it's the same. You're going to provide wound care. You're going to provide wound care whether they had a laparoscopic or whether they had a big old open incision, whatever. If they had an open appendectomy because of a rupture and they had to leave it open because of peritonitis, then they may need a wound vac, okay? A sponge connected to a vacuum that is sucking out all that infectious waste in there. If they have a wound vac or extensive wound care, they're going to require a wound ostomy care nurse. Or if they have a new colostomy, they're going to need a wound ostomy nurse. And then expect they'll probably have a gastroenterologist, a surgeon, and a nutritionist, dietitian, whatever, to teach them about new diet. These are things, consults you're going to see. Um, Again, monitor for signs and symptoms of infection. So we talked about infection and inflammation last week. What is that? Red, swollen, painful, and hot, right? Red, swollen, painful, hot. Those are signs of inflammation and infection. So if you're assessing someone's incision and it's looking pretty red, angry, if it's looking swollen, you want to let the surgeon know. You want to let the doctor know because they're going to need antibiotics. An infection underneath an incision can have devastating effects. This at the bottom here is called dehiscence. It usually occurs because an infection was brewing up under the skin and you didn't even know, except for it was probably just red, and then now it's busted open. There's no room in there. That exudate or pus has to get out of there. That infectious stuff. So evisceration will be you had the infection, it was so bad, it's busted open, and an organ has now popped out. So sorry for the graphic pictures, just trying to make sure you understand what can happen, why we do what we do. So you're going to need to know about different diets, like if they got a colostomy, you know, how to prevent odor, how to prevent gas, how to prevent diarrhea or bulking up the stool. If it, yeah, Brittany, it's nasty. I know it can get bad, can get ugly. This nursing, it's not for the weak. It's certainly not. Abdominal surgery. You always teach them to cough and deep breathe and use incentive spirometry every 1 hour. Does everyone know what incentive spirometry is?
Yeah, that's the thing that you blowing.
No, you breathe in. You blow
Breathe.
in the thing for asthma, right? That's called a peak flow. We'll talk about it when we talk about lungs. That's the thing you blow in. That's a peak flow. When you have abdominal surgery, or a lot of surgeries, you need incentive spirometry. Your inspiration, you're inspiring, you're breathing in, okay? That is to make them expand the lungs, you know, as far as they can. I want to show you. I forgot to show the other class last time, but now let me make sure I don't pull up the wrong. Okay, I don't pull up the wrong stuff. Pull up the whole exam again. Lord have mercy.
Pull up your test.
I know that would be nice, wouldn't it? Hold on. Incentive spirometry. I just want to show you, you know what it is if you've been in the hospital. This thing. This is the device they use for incentive spirometry. They're going to breathe in deeply. They're going to cough and deep breathe every 1 hour after surgery. Why is it saying my internet is unstable? F it. Okay, forget it. You saw the device, right? You saw that? Everybody saw that? Oh, use it during every commercial. Yeah, that's a good idea. Is it still breaking up? Am I breaking up?
No, now you're good. Before.
Okay, okay. I don't know what happened. Janky old Wi-Fi connection. Okay, but you guys see that you saw the device, right? You know what an incentive spirometry is. We'll talk about it again when we get to lungs, but everything's connected, okay? And then of course, you know, pain meds. Remember, opiates may cause an ileus, okay? So you want to be mindful. A lot of surgeons, you'll see, they want to get the patient who's had abdominal surgery off opiates as quick as possible because it leads to constipation or paralytic ileus. Bowel sounds, again, if somebody had abdominal surgery, you must assess the bowel sounds. Every shift, every couple hours, you need to be assessing. A monitor for signs of peritonitis, monitor for signs of an ileus. And then when someone has surgery, when they have a wound, anything, things that delay wound healing, infection, diabetes, low protein. So people with wounds need a high protein diet. You don't need to know that right now, but I'm just telling you, these are things that will delay healing. Corticosteroid use, because again, it's suppressing the immune system, right? So corticosteroid and immune system suppressants are going to delay wound healing. And that's it. Everybody good? Any questions about anything? Now, let me try again, not to share the wrong thing. I'm gonna mess everything up. Have my social security number and my bank account up here. That will be a comedy show. All right. Now, let's see. Your brain is traumatized. Kanisha, girl, too much? You the one that wanted to come to the school to learn all the nursing 1 day a week. It's a lot. It is a lot.
Professor Cook, I have a question.
What's up?
Going back to when we were talking about the psoriasis.
Cirrhosis.
Uh-huh. I kind of got a little bit lost when we started talking about the esophageal varices. Is that kind of what happens due to the excessive scarring? I kind of got a little.
So let me go. I'm gonna open that back up. You can still see my screen, right? Yeah. So let me go back. Let me show you this picture too. Yes, what's happening is there's scarring and damage to the liver, right?
Mm-hmm.
The scarring and damage, the scarring and damage to the liver. Hold on, where's the liver? Because I want to show you the actual, or where's the esophageal varices? Here, the scarring and damage to the liver is impairing the function of the liver, right? And one of the functions, I'm trying to zoom in, so well, let me just put it like that. All right, so you see this here. The blood, the liver receives blood from the intestines, the GI tract. Why? Because we got food and we got medications and things all going through the GI tract. So while they do some absorbing here, all of the blood from the intestines goes to the liver, right? To be filtered. The liver filters out toxins. The intestines do some of that, but the liver does a majority of that too. So when the liver is scarred up and it's not functioning properly, it's not going to be able to filter the blood at the rate it used to when it was healthy. So now you have blood going backwards. So instead of, you see these arrows going that way, instead of the blood going this way towards the liver and then back up to the heart into circulation, it's now going backwards because it's getting congested. It's traffic up in here because the liver is not functioning. So now it's moving backwards. And because of that, one, the pressure is high. There's too much blood in this whole vascular system now because it's backed up. So the pressure is high. And that pressure is causing blood going backwards. And remember, if you followed the entire GI tract, right? If you followed it all the way up, we'll leave it right here. If you follow, let me show you. All right, so if you follow the GI tract, right? Here's a portal vein, and blood is flowing backwards into the intestines. Remember, it's going to go up into the intestines. Then that blood is still, now it's not inside the intestines, it's the blood vessels on the intestines that bring, you know what I'm saying? So it's not a blood inside.
I see.
You get what I'm saying? Okay. So
Yeah, got
it's bringing the blood's going backwards. It's backing up, it's backing up, it's backing up. And what's happening is you're getting varicose veins in your esophagus. Does that make sense?
Yes, it does. Thank you.
Okay, cool. So same thing when we get to circulation and you learn about varicose veins in the legs, it's the same thing. There's been high pressure, the valves are leaky, blood is flowing backwards. It's not all going forward. Blood should be only flowing in one direction in your body. But when it starts going backwards and the veins become congested, they become engorged, swollen, full of blood and ready to bust. So that's what happens with esophageal varices. The scarring has impaired the function of the liver, and so it can't filter the blood as fast. And now there's pressure in the portal vein. That pressure.
Sorry, Miss Carly. If you're prone to varicose veins in your legs, you can get them in your throat.
No. I'm just showing you that it's the same idea.
Okay.
Getting them in the throat comes from liver failure. You should.
Okay.
No. If you get them in your legs, no, you probably either have high blood pressure, you're wearing the wrong clothes, you're up on your legs too much. But no, you're not going to get esophageal varices just because you have varicose veins. I'm just saying, but what they are, they're like varicose. That's what they're called. They're engorged veins. That's what varicose means. They're large engorged veins.
Okay, you scared me.
Oh, girl, no. Now, if you're a raging alcoholic and end up with cirrhosis, then yes, you could get varicose veins. But no, not from having them in your legs. A lot of us have them. Those are cosmetic. That's totally different. It doesn't mean you have a disease. It's usually related to work. It could be hereditary.
Okay.
I was just saying I was just trying to make you imagine how big these veins are in your esophagus and why them rupturing could kill you quickly. So
right.
like big bulging veins in the throat. Well, esophagus, whatever. Prednisone. Prednisone would delay hearing. Yep, prednisone is a corticosteroid. So a glucocorticoid, same thing. It will delay healing because it impairs the immune system. It suppresses the immune system. Your immune system is what heals you. So if your immune system is suppressed, if you're on chemotherapy, same thing, and you get a cut, it's not going to heal the same way. So immunosuppression. Anybody else have a question? No question is stupid. I swear to God, no question is stupid. Closed mouths don't get fed. So don't sit here and think, oh, I'm not gonna ask that. I don't want to look stupid. I don't listen to me. I don't really know how to pronounce half these words anyway. Okay, and I really, I can teach because really my only students have always been patients. So I can't, they don't know what synthesize means. I can't say that to a patient. They don't care either. So anybody else before we move on? Anybody? All right. All right. Let me move on. What time is it? Oh, it's 2:00. All right, we do some questions just to see how much information Kanisha can get in her brain. We're gonna do some questions real quick. And then you're free. We'll go through the study guide and get out of here. Oh, Lord. Y'all are so quiet. I hate this. I cannot wait. Just so you know, we're on campus next week. So tired of sitting here looking stupid at my computer. That's why I turned my camera off. Ugh. Yes, Carly. And maybe we should do a bring your mom to work day. I mean, to school day. Your mom should come to school one day. Ugh. She'd probably love that. She should be a teacher. Oh, see? Oh, you guys know her mom already? She should be a teacher. Well, she is teaching clinical, right? Yes. Tell her to come on back. We need good teachers, not mean, evil teachers. It's a lot of mean teachers in nursing schools across the world. I don't know what's wrong with these people. Bunch of insecure women out here in the world. What's wrong with us, Lord? Oh, just got to be mean to each other for no reason. Oh, she's crazy? Even better. Well, there's good crazy and there's bad, really bad crazy. All right. So, actually, I didn't even need to come to this. I could have just opened the crap on my computer. Mental health clinical. I'm not doing a clinical. Sorry. I guess Tara sent this to everyone. You guys doing mental health clinicals now?
Yes, on campus.
She tried to roll up on Christina Christmas. What happened? Wait a minute. What? Whoa. Oh, God. All right, let me make sure I teach right. Shoot, she popped up on that screen. I was like, who's that? I'm about to get written up for talking about Professor Colia. Shoot. It's true though. Some nursing instructors are crazy as heck. All right, I'm sorry. Don't look at how I'm so disorganized. I got files everywhere. No, not there either. All right, forget it. We'll do liver, pancreas, biliary, so you can feel better about all that information that just got crammed in. I don't know if you guys, anybody looked at these yet. It's not ATI, but it doesn't matter because hepatitis is hepatitis. The same type of questions are going to be on your exam. So let's look at don't do that. Look at number 1. You have a patient has a diagnosis of a biliary obstruction from gallstones. What type of jaundice is the patient experiencing? That's in your book.
Obstructive jaundice?
Yes, obstructive jaundice with elevated bilirubin, right? Good job. All right. Patient experienced a blood transfusion reaction. How should the nurse explain to the patient the cause of hemolytic jaundice that occurred? Anybody? Oh,
D?
here's a chat.
D?
D as in dog.
Ruff.
Yes, due to increased breakdown of the red blood cells. See, y'all know stuff. You know, hey, yes, hoes, yes, we know stuff. Yes. See, it's not that bad, guys. You're smart. Patient returned from a 6-week mission trip to Somalia. What do you think they had? Read the question. You can read.
Hepatitis E?
Hepatitis E. Oh, what made you know it was hepatitis E?
Because they in Somalia.
So why didn't you pick D? Why didn't you pick Hep D?
Because of the nausea and the malaise and the achy muscles.
And also what?
You have to have B before you can.
Yes.
True that. True
Look
that.
at you guys. Okay, so you have to have Hep B to even get Hep D.
Yes.
Nowhere in all they did was go to Somalia. They didn't go, they weren't, it doesn't say the Hep B positive patient went to Somalia, because then we would have to wonder. So good job, Hep E. Next, which type of hepatitis is a DNA virus, can be transmitted via exposure to infectious blood or bodily fluids, is required for Hep D virus to replicate and increase the risk of chronic carrier hepatocellular cancer.
B.
Everybody, yes, 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 Hep B. See? These questions look hard as heck, but they're not. We already talked about this in lecture. You're reading about it in your book. It's not, I mean, I'm not going to say it's not rocket science, but if you listen and you study, you can take these tests. You can pass these tests. So the serologic findings, now some of them I will tell you the answer if it's too hard. Serologic findings in viral hepatitis include the presence of viral antigens and antibodies produced in response to the virus. What lab results indicates that they're immune?
B.
It's the antibody. Antibody. C. Remember I told you, if you're looking at the slides, remember I told you on that slide, I wrote it wrong. Yes, C, Kanisha. C, I mean, girl, and you're talking about your head hurts. It's C. It is the antibody, okay? The antigen may be present, but if they have produced antibodies, it's because they got the immunization. All right. The patient asked why Hep B DNA quantitation is being done. Why do you think? This one might be harder, but why do you think? D, yes, D. To assess the effectiveness of therapy. DNA, RNA quantitation is to affect, it's the viral load, and it's to assess the effectiveness of therapy. So, although Hep A virus antigens are not tested in the blood, they stimulate specific, now this has to take you back to last time, immunoglobulin M and G. Which one is acute? Do you remember?
IgM.
Yes, IgM. IgG is the memory. IgM is elevated in acute infection. Yeah, it's IgM. Because if you think about it, in the hospital, a lot of times you may have heard of people getting an infusion of IgG. That is to give that person increased, like, long-acting immunity. IgM, I know, I wish it was M for memory, but it's not. So just remember, it's not M for memory. It's not. IgM is acute. G is the memory, okay? Now, oh shoot, what did I do? Oh no, that's Hep B. Yeah, so Hep A. This is, you're testing for Hep A, so it's gonna be IgG. I mean, sorry, IgM. Sorry. What tests will be done before prescribing treatment? You guys aren't going to know this. It's genotyping, but you really don't need to know that. You're not treating Hep C. So what causes, but what would RNA tell you? Because if they have positive Hep C, you need to get the RNA to know that they actually have a Hep C infection, okay? Some people are able to produce antibodies and keep that Hep C from causing a real infection. So you have to have an RNA. But if you were going to prescribe treatment, which you don't need to know, it will be genotyping. So anyway, moving right along. What causes the systemic effects of viral hepatitis? Remember, it's a virus. So viral hepatitis, what causes the systemic effects? D, yes, it has to do with the immune system, okay? It's not toxins, the liver is not producing toxins. That's not what it does. And it's not, portal circulation is for cirrhosis, and cholestasis. Stasis means a fluid is sitting still, bile sitting still. That still isn't viral. That's not what viral. All these things will cause liver disease, but that's not what viral hepatitis is doing. Everybody get that? During incubation period, this one's tough too. What would you expect with the incubation period of viral hepatitis? Let me see how I can get this chat not to be so doggone big. Okay. Yep, the answer is C. Ashton, you're killing it. What the heck? Shoot, I'm scared of you. Anorexia, right? The pain is gonna be in the incubation period, okay? Again, you don't need to know this for your exam, but hey, push your brain to the limits, okay? Occurrence of acute liver failure is most common in what? Number 11. Anybody else want to answer?
D.
D. It is D. Alcohol, alcohol, alcohol. There was a time it was like all over the news. All these college students kept dying because they're binge drinking at parties, and they're dying from, and they're saying, oh, alcohol intoxication. I mean, what do you call it? Yeah, what is it called? Alcohol overdose, whatever. Anyway, that is what they're dying from, acute liver failure. It is either from or Tylenol. If you've ever heard, when people commit suicide by ingesting, overdosing on Tylenol is the worst way to probably kill yourself. Like, it's a slow, painful death from acute liver failure. Okay. Now, needle stick injury. This is going to be the same for newborn babies. This is likely going to be on your exam in some way. What is the prophylaxis against Hep B? Just like a newborn born to a mother with Hep B, what is the treatment and prophylaxis? It is B, but there's also more. It's D. Yes, Adria. Kanisha, girl. Oh no, Kanisha said B. Never mind. I was gonna say, girl, and you said your head was hurting. D, D, D. You're going to newborn babies. Remember, I say you're gonna give them the IVIG, Hep B, IG, immunoglobulin, which is just exogenous, outside the body made antibodies to Hep B. And then 12 hours later, you're gonna give the newborn baby a vaccine. Same with the grown adult who's done stuck themselves with the infected needle. You're gonna treat
Can
them.
I ask a question?
I'm sorry?
Can I ask a question?
Yes.
I feel like, so I've had a few needle sticks. I've never had that I can recall, a vaccine or whatever that other.
Have you ever stuck yourself with a needle after sticking a patient with Hep B? This is if you knew the patient had Hep B.
Okay, I was gonna say, I've never had that.
HIV, same with HIV. Sometimes.
Yeah, they only do blood work,
Yeah.
immediately
We're
6 weeks
just
out.
If they were infected, what would you do?
Okay.
Sorry, they didn't give you that part. But if you
I'm
were,
surprised they don't just assume that somebody would be, just like they assume people have HIV.
well, that's why quickly, usually, like a lot of places I've worked, if you get a needle stick injury, 9 times out of 10, you don't know what the heck these patients have. So what they do is they test the patient. A lot of times it's a lot quicker to just test the patient and see if they're positive. If the patient doesn't have Hep B, then you don't need to go get an IVIG and vaccines if the patient is negative. The patient doesn't have HIV right now, they're probably not going to infect you with HIV. So usually they'll test the patient because that's going to be a better indicator. Because remember, if you just got infected, they have to keep drawing your blood. So I have worked in the hospital and stuff, a lot of places, they'll just test the patient right then and there. Now, so family members of a patient with Hep A, they want to know, is there anything, is there anything they can do to get this thing off my screen, Lord, to prevent, you guys can read. What do you think number 13 is? And again, you might not know this, but just take a good guess, because if you think about it, you probably will guess right. The answers you guys put, B, C, what's the answer? The answer is actually the immunoglobulin or immune globulin. That is actually because now you would give someone a vaccine to prevent it, but because we know these people have likely already been exposed to the disease, then we give them immune globulin. It's a vaccine isn't going to work well enough if you've already come in contact with the disease. So that's the idea. And not that you need to know this particular question for your exam, but if you really think about it, like I said, if you think about, you know, inflammation now, you know a little bit about the immune system and how it works and how vaccines work. A lot of times, even if you never learned the material, if you know how the body works, then you're able to kind of come to a good guess. Patient diagnosed with chronic Hep B asked about drug therapy to treat the disease. This one, again, you don't need to know, but yep, you really, and that's the thing, a lot of these questions you really need to pay attention to. So this one, again, you don't need to know, but there is treatment for Hep B. You can give them antiviral medicine and interferon, which is another component, like an immune complement, like immune globulin. The nurse identifies a need for further teaching when the patient with Hep B makes which statement?
B as in boy.
B as in boy, yes. You can hug your family, you can kiss your family. You're not going to pass Hep B to your family by having physical contact with them. So you don't need to isolate yourself, but you do need to isolate as far as like, you don't want to, maybe a lot of times I'll tell patients, don't put your toothbrush by each other, because not because of the saliva, but because you may at times have bleeding gums, things like that. You just don't want to expose your family to blood. But other than that, you know, yes, you should avoid alcohol. Yes, you should use a condom. Yes, you need rest. So what is one of the most challenging nursing interventions to promote healing in a patient with hepatitis? The answer is, anyone? A, providing adequate nutritional intake. Healing, remember, malnutrition, people with viral, any type of liver problem, they're also going to probably have, you know, bile. The liver produces bile. They're going to have problems with digestion. They're going to have abdominal pain. They're going to have nausea. Not only that, you're trying to give them a low protein diet, and nutritional intake affects healing. The answer, the biggest problem that liver patients have is malnutrition. And that's a lot of, I mean, any GI disorder. Promoting strict bed rest is good, providing pain relief, but as far as delaying or promoting healing, it's got to be nutrition. When caring for a client with autoimmune hepatitis, the nurse understands what in this patient is different from the patient who has viral hepatitis.
C.
C, yes. It's autoimmune. We're treating it with steroids and immunosuppressants. If we're treating it with steroids and immunosuppressants, what are the precautions we need to be worried about? We need to be worried about infection. Anything that's going to lower the infection and healing. Anything that's going to lessen the immune system. I'm skipping over this because we're not talking about that. Your patient presents with itching, steatorrhea, and liver enlargement. This patient has also had ulcerative colitis for several years. What do you expect?
I think it's A.
A, cirrhosis. Oh, I'm sorry, no, not A, D. And you probably wouldn't know this, but it's primary sclerosing cholangitis. It's inflammation and scarring of the bile duct. And that's, don't worry about that. Skip that question. I need to move on to yeah, these questions are good. Cirrhosis, okay? Patient is an older woman with cirrhosis who also has anemia. What things are changing in their body that could cause this? What's going on with them? Why does a cirrhotic patient have anemia? Oh, it's in the chat. Sorry. Taking so long.
Vitamin. So A.
What number am I on? 20?
20.
We say A, yes, they're gonna have vitamin deficiencies. They are going to have vascular congestion of the spleen, because remember, they're right by each other, and the liver is not functioning as well. And they are going to have a decreased prothrombin production. The liver produces clotting factors, and the liver, when you have liver failure, I don't think I mentioned that to you guys, liver, but it's in the PowerPoint. The liver produces a lot of clotting factors. So because of that, when you have cirrhosis and liver failure, your blood is thinner. It's not able to clot as fast. So that also contributes to them bleeding out when esophageal varices rupture. The labs you're going to see is elevated PT, INR, PTT, all their clotting factor or coagulation tests that are looking at the time it takes for your blood to clot. Those are all going to be elevated or prolonged, the time it takes for your blood to clot. And then we already know they're going to have malnutrition. This is a patient was diagnosed with non-alcoholic fatty liver disease. So this is, like I said, cholesterol buildup can cause that. What treatment measures would you plan to teach?
A and C. Not C. A, D, and
Yep, it's A, D, and it's also B. You may not know that yet. Yep, A, B, D. Oh, good job. Yep, A, B, D. You may not, we haven't talked about diabetes, but there is a thing called metabolic syndrome. It's usually people, they are obese, they have diabetes, they have high cholesterol. A lot of times, and they may or may not have diabetes, but usually that obese, high cholesterol, they end up with fatty liver disease. So you're going to teach them about weight loss, diabetes management, and then management of the high cholesterol. Which manifestations may be seen in a patient with cirrhosis related to esophageal varices? C, yes. Remember I said your body's going to try to make those new channels, collateral circulation. The esophagus is already, they're fragile, they're engorged, and it is a result of that portal venous hypertension. Good job. See, you guys are learning. Which conditions contribute to the formation of ascites? What's going on? D, yes, Adria, it's D. Now, Kanisha, this is how they wanted to trick you. We'll talk about osmosis and fluids next week. You were right, Kanisha, in thinking decreased albumin, because that's right. It causes fluid to leak out. But the reason it causes fluid to leak out is because the colloidal oncotic pressure is decreased. So they tricked you because they know decreased albumin. So that was still a good guess because you would have had to know what the heck this meant right here. So the answer is D, and it's because of the portal hypertension. Because of the increased pressure, all this fluid is leaking out. It's just everywhere. You got collateral circulation. It's just everywhere. So 24, when you're looking at the labs of a patient with cirrhosis, what do you expect to find?
B.
B as in boy. Remember, bilirubin is a greater than 1 is elevated, okay? So 3.2 is elevated. AST, this is normal. This albumin is high, and you would expect a low albumin. So the only, and this is high cholesterol. Yes, if their cirrhosis was due to fatty liver disease, and yeah, they would have a high cholesterol, but that's not what the question was asking. But you would see a 3.2 bilirubin in someone with cirrhosis. Malnutrition can be a big problem for patients with cirrhosis. Which nursing intervention can help to improve? It may sound crazy, but it's the right answer. What would you pick?
A.
A, oral hygiene. Do you want to eat when you first wake up in the morning and your breath stinks and your mouth tastes nasty? No. Oral hygiene, good oral hygiene will not only prevent infection, but it is part of promoting good nutrition. Also, you don't want decayed teeth. You're not going to be able to eat with rotten teeth. Or gum disease. It's painful. Patient being treated with diuretics for ascites from cirrhosis must be monitored for what? You took pharmacology last semester. What are you going to monitor when they're on diuretics? B and C, yes. Hypokalemia, renal function. Hypokalemia is a low potassium, and we'll talk about that more next week. But knowing that you took pharm, you're always, everything you learn in nursing, you're building on top of knowledge. So like I said, I'm gonna try to refresh whatever knowledge you were supposed to get before you got here. But everything we're doing, you're building on top of that knowledge. Everything you do, you gotta constantly keep learning. Shoot, I had to read your books to remember half this stuff. Not this stuff, but some of this stuff. All right, manifestations in a patient, or what manifestation in the patient does the nurse recognize as an early sign of hepatic encephalopathy? The answer is D, irritable and lethargic. Early, remember I said it's gonna lead to a coma. So becomes unconscious, that's gonna be in end stage. Oliguria is no urine output. That doesn't really have anything to do with it unless they went into shock or their nervous system was so depressed that they can't void. But irritable and lethargic, that's gonna come first. And a lot of times, people with cirrhosis, people will assume they're drunk and they're not. It's just the ammonia buildup and they have encephalopathy. To treat a cirrhotic patient with hepatic encephalopathy, lactulose, I can't even say that, Xifaxan, and a PPI, proton pump inhibitor. Those are ordered. Family wants to know why the laxative. And the answer, C. See, y'all gonna pass the test. Does everybody feel good about themselves now? Is your self-esteem soaring right now? You feel like, oh my God, I'm ready. I could work. No? Jenny, come on. Give yourself a break here. Okay? You're doing great. All right, we'll keep going then. More questions. So yes, the answer was C. Lactulose traps the ammonia and it eliminates it in the feces. What about this? Your patient has hepatic encephalopathy. Here's one of those nursing type questions. What is a priority nursing intervention to keep the patient safe? Safety first. And the answer you say is C. Adria, C. You're going to worry about them falling. This is going to be the imminent danger to the patient. Yeah, you want to prevent constipation, but that is not going, constipation isn't what's causing the ammonia production, okay? You're just giving them a medicine so they could excrete it from the stool. Constipation, it's liver failure that's causing the ammonia buildup. It's okay, you guys. We this is how you learn. You keep practicing and you talk about it. But safety, if they get up and walk, I mean, I wouldn't encourage them to get up and walk. They're weak, they're confused, they're they're having an altered mental state. So you could assist the patient in walking, or they could just stay in the bed. Either one. So patient with advanced cirrhosis has a nursing diagnosis of imbalanced nutrition, less than body requirements related to anorexia and inadequate food intake. What would be an appropriate midday snack?
A.
What is the diet for the liver? Liver failure.
Protein.
Low protein. Peanut butter is high in protein.
So let's go with
So D.
D is wrong because it
canned.
says canned fruit,
Okay.
which is high in sodium.
So B.
B, yes, a freaking tomato sandwich, whatever the heck that is,
That sounds
with
good.
butter, okay? Whatever that is right there, that is what, yeah. I don't think that's gonna promote adherence. I know what I could get you, a freaking tomato sandwich with salt-free butter.
There you go.
So this right here is why you don't want to get cirrhosis, okay? You don't want to be eating a low protein, nasty old tomato salt-free butter sandwich, okay? Now, patient with liver failure. Oh God, what does the chat say? Meat and potatoes. Exactly. You'll have to quit. Yep, dump the alcohol in the sink as I speak, okay? Patient with liver failure had a liver transplant. We don't need to know what the surgery entails, but what you need to know is what you need to teach that patient about and what is going to be important to teach someone with a transplant. D, yes, you're monitoring for infection. They are going to be usually on lifelong immunosuppressant drugs, okay? You're going to monitor closely for infection. They're going to be at high risk. During the treatment of the patient with a bleeding esophageal varices, what is the most important thing the nurse should do?
C.
C, airway, airway, airway. Yes, if you don't know that, airway, airway, always, even before the heart, unfortunately. Airway, A, B, C. Remember, C, circulation, cardiac, airway first, okay? They try to trick you through that cardiac in there. They try to really make you think. But also think about what's going on. Esophageal varices, they're bleeding in the throat. They are bleeding profusely in their throat. What's going to happen? We need to protect the airway. Patient with cirrhosis that is refractory to other treatments for esophageal varices undergoes a shunt. I didn't talk about this, but let's just take a guess. What do you think a shunt would do?
Hey, doesn't that like help you breathe?
A, maybe, but the actual answer is D. What a shunt is it's going, yep, D. It's going from, okay, so you had that, let's go back to this. This portal vein is going to be huge. It's swollen with blood, right? What they do is they create a new canal, a shunt, and it's going to go from, it's called a TIPS procedure, transhepatic, I don't know, intrajugular peritoneal shunt, I think. I don't know. It's in your ATI book. Don't worry, I'm not going to test you on it, but I still want you to understand what shunt means because you'll hear it again many more times. Shunt is they're creating a canal to bring this blood that is backing all the way up into the GI system. It's a canal to bring it up to the neck and into the jugular veins to put it back into circulation with the heart, right? Because you just have a bunch of blood pooling in the GI system. But if you can make this, you're not going to see this. Has anyone ever seen a baby with hydrocephaly? The baby that have a lot of fluid on their brains? Again, that they get a VP shunt. They get a shunt. It's a canal releasing the fluid from the around the brain, and it's a tube it's inside their body. You're not going to see it. It's inside their body, and it's going from their brain down to the belly. But this kind of shunt is going from, it's shunting means it's making a new path. It's going its way around. You're shunting blood from this engorged portal venous system back into circulation up in the jugular veins. Oh, your cousin, see? So it's not something you could see, like these like babies with hydrocephaly live a normal life as long as they have a shunt. But that's just what a shunt, that's what that term means, okay? But again, if you just think about it, they're removing the pressure. And when you have blood pooling, you don't have enough blood going to the kidneys, perfusing the kidneys, bringing oxygen to the kidneys. Anyway, moving right along. Long-term management with the patient with alcoholic cirrhosis, what should the nurse advise the patient? This is pretty easy. C. I shouldn't have said it was easy because then nobody wants to guess. I'm sorry. I will never say that again. Abstinence from alcohol, most important. The rest, yes, but abstinence from alcohol, that is going to be the thing that's going to kill them. Patient is hospitalized with metastatic cancer of the liver, blah, blah, blah. Oh, you don't need, I mean, you're not going to probably know this one. But we'll talk about liver later. I mean, we'll talk about cancer later. But if it's metastatic, the prognosis is poor. So the only thing you would be talking, I mean, not that they wouldn't get chemo, but usually it's more supportive care when it has metastasized to the liver. The liver is so vital. That is why cirrhosis is going to kill you, or I'm sorry, liver cancer is going to usually kill somebody because the liver is just such a vital organ. It has too much responsibility to really be sick like that. So you're teaching about a transplant. What are you going to teach? And I'll just finish this page and let y'all go. And this is that therapeutic communication, D as in dog. So let's talk about it. Liver transplants are indicated only in young people with irreversible liver disease. That's not true. And why would you tell somebody that? That's just rude, okay? If you're interested in a transplant, you really should talk to your doctor about it. Again, yes, that sounds right, but it sounds rude, okay? You're working right there with the doctor. They brought it up to you because you're the nurse. You're the liaison between them and the doctor. 99.9% of the time, the doctor goes in, the patient talks to them, all kinds of crazy stuff, asks them, do you have any questions? The patient says, oh no, I don't have any questions. And then you come back in there and they got 99.9 questions. And you're like, what the hell? I just heard you tell the doctor you had no questions. So them asking you is really, I mean, you're the one that's going to go tell the doctor. Rejection is such a problem in liver transplants that it is seldom attempted. Come on now, why would you tell somebody that? This is the most appropriate answer. Have you talked to your doctor about this? Okay. Think about it. A lot of those mental health and therapeutic communication, a lot of them, if you really read it out loud to yourself, think to yourself, like, if I was a patient, what would I be thinking? Like, oh, okay, B, all right, cool. Yeah, I should talk to my doctor, bitch. You're going back there. Aren't you about to go talk to him? That's what I would be thinking, right? Which complication of acute pancreatitis requires prompt surgical drainage to prevent sepsis? Anybody? What do you think is going to lead to sepsis? D, yes, the D, the pancreatic abscess. Okay, that is going to quickly lead to sepsis. Okay. When assessing a patient with acute pancreatitis, the nurse would expect to find what? The answer is D, as in dog. Severe mid-epigastric and left upper quadrant pain. They might have elevated blood pressure, or they might be hypotensive. They are probably going to be tachycardic because they're in pain and everything else. They may or may not have a fever, but if it's that high, they probably have peritonitis. But the severe pain is the real symptom with pancreatitis. It's extreme. They need opiates usually to treat the pain, and hence one of the complications of chronic pancreatitis, it can lead to narcotic dependence because they have that constant pain, severe pain, and especially after eating, and we all need to eat to live. Combined, oh, I'm sorry, you want to keep going? Or are you guys done? Are you done for the day? Are you tired? I emailed you guys these work. I didn't email them. Sorry. They're on Moodle with the answers and rationales. So we could keep going together a little bit longer. Or if you are so tired of hearing about this, then I will let you go. Anybody?
Is that the last page?
She said, I'm done. Huh? You said what now?
Is that the last page or is more?
Oh, you see where my little thing is right here? Girl, it's gonna keep going. But the last 2 pages is yeah, you see this? You see this?
Oh, no.
Yeah. Well, that last page, that's a case study. We're not gonna do that. But I do have these, like I said, this is already on Moodle with the answers. Because I know we've been talking a long time.
Yeah.
I've been talking a long time. All right, everybody's good. Yeah. Unless you absolutely want to keep going, I will keep going. Is there anybody? Let's put it like this. Does anybody actually want? Okay, good. Okay, I didn't want to cut anybody off if they were like really into it or whatever, but I think at this point everybody's done. Okay. All right. So it's on Moodle with the rationales. If you have any questions, reach out to me. As far as the study guide, I mean, it's pretty straightforward. You should be able to look at that and see, you need to know the signs and symptoms of stuff, certain things. You need to know, aggravating, alleviating thing for GERD, positioning, yada, yada. It's pretty straightforward. If you have any questions on the study guide, then text me or send me an email. Other than that, it's been great. Everyone have a good night. Have a great weekend. And next week on campus, exam on campus. Let me know if you need any help. If there was any questions you were too scared to ask in front of your peers, just let me know.
Is it mandatory that we go to class?
Is it mandatory you go to class? That's what they said. That's what the email they had me send out a couple weeks ago. That was what Nolan said.
Okay.
I don't know who's this.
Alina.
Okay, Alina, you email me and I'll ask Nolan about it. But yeah, I haven't been told that anybody could stay home. So yeah. Well, yeah, and next week's the exam too. So all right. Well, email me and I'll follow up with Nolan and let you know. But I'm gonna say yes, it's mandatory at this time.
Okay.
All right. Have a good night, everybody. Have a good weekend.
You too.
You be safe on your travels.
Oh, thank you. It's my birthday.
Oh, happy birthday.
Oh, thank you. It's Sunday. Yeah, I'm going to Virgin Islands. I'll be back on Monday. Don't worry. I'm
Enjoy.
with my laptop because I'm just lame like that.
Okay.
So, have a good weekend, everybody. Lord knows I will. All right.
Yes, girl. Live it
Bye.
up. Okay. Bye-bye.